Due to COVID-19, today's hearing is being held remotely. All members and witnesses will be participating via video conferencing. As part of our hearing, microphones will be set on mute to eliminate background noise, and members and witnesses, remember to unmute your microphone each time you wish to speak. Documents for the record should be sent to Megan Mullen at the email address we've provided to your staff. All documents will be entered into the record at the conclusion of the hearing. The chair now recognizes herself for 5 minutes for an opening statement. Senator Edward Kennedy wrote a letter to President Obama to be opened after his death. And in it, he said that the cause of ensuring that, quote, the state of a family's health will never again depend on the amount of a family's wealth, and was the great unfinished business of our society. When President Biden signed the American Rescue Plan earlier this month, he took another step toward that unfinished cause. Covered California estimates that about 25 million Americans stand to benefit from the new and expanded subsidies to lower premium costs in the American Rescue Plan, including 3 million Californians. For the millions of people who collected unemployment insurance at any time this year, they can now get covered by a health plan with a zero premium and added help to lower the cost of deductibles and co-payments. After 4 years where millions of Americans who depended on the ACA lived in daily fear that they'd lose their health insurance because of a decision by the former president, I have good news. Your ACA coverage is safe and it's a lot more affordable. But the cause is still unfinished, especially in the 14 states that have not yet expanded Medicaid. In those states, about 4.3 million Americans are locked out of health coverage despite being poor because their governors or state legislatures have so far refused to expand Medicaid. Let's take Texas, for example. According to the nonpartisan Kaiser Family Foundation, if you're a parent in a family of 3 and make more than $3,700 a year, you would be making too much to be eligible for Medicaid. If you're an adult without kids in Georgia, North Carolina, Florida, Texas, or any of the other states that didn't expand Medicaid, you're ineligible for Medicaid, even if you have no job and no income. There isn't any healthcare safety net for childless adults in those 14 states either. The American Rescue Plan offers those 14 states as much as $22.7 billion to correct this injustice. This federal support is in addition to the guarantee that the federal government will pay for 90% of the cost of expanding Medicaid to this new population. Beyond Medicaid expansion, unfinished business remains. Today, we'll consider 18 bills, many of them bipartisan, to increase enrollment, lower costs, and improve coverage, especially for children and people with disabilities. To help us better understand how to finally achieve our North Star of universal health care, we'll also hear testimony from experts on Medicaid and private insurance, as well as from the patient and provider perspective. And we all look forward to the testimony that we believe will be highly instructive. Senator Kennedy closed his letter to President Obama with the following, quote, "What we face is above all a moral issue, that at stake are not just the details of policy, but fundamental principles of social justice and the character of our country." Today, on the 11th anniversary of the passage of the Affordable Care Act, we will consider the details of the policies before us. But let's also work to restore the character of our country through this important work as well. The chair now recognizes Mr. Guthrie, the ranking member of our subcommittee, for 5 minutes for his opening statement. And remember to unmute. It's great to see you, Brett.
Great to see you. Thank you, Chair SU, and thanks for holding this hearing. However, I do think we have other pressing items or more pressing items that we should be looking at within our jurisdiction before looking at how to fix the Affordable Care Act. We have a crisis at the border where HHS office is taking charge of taking care of unaccompanied children, and they're being overwhelmed. Some reports indicate there are over 15,000 children in their control, where there are only 13,000 licensed beds for them. We should also be looking at the impact of COVID-19 on mental health and substance use disorders, including programs this committee worked on to pass in CARA, 21st Century Cures, and the Support Act. We also need to be examining how to lower healthcare costs. This hearing's title does discuss lowering healthcare costs, but I'm not sure the bills today do, but rather the bills continue to subsidize expensive insurance. The majority has called us here to look at ways to shore up the Affordable Care Act, which became law 11 years ago and is still not working. The ACA has increased premiums dramatically, and many insurers stopped offering coverage. In my home state, Kentucky was found to have the 6th largest rate increase in annual health insurance premiums at 27% over a 6-year period. This is not sustainable for workers and families. Democrats have chosen to address it by pumping more money into the Affordable Care Act and limiting state flexibility instead of addressing what is the real problem, the high cost of health care. Even the generous subsidies that Congress just passed this month are apparently not enough to make these insurance plans attractive, as we're back again to discuss more spending. By my count, on top of the $1.9 trillion that was just spent, today we're discussing at least another $45 billion or so based on scores I could find from the last Congress. Compared to $1.9 trillion, $45 billion may be small, but it's almost the entire annual budget of the National Institutes of Health. Before we authorize billions more on top, we need to first see how the funding from the $1.9 trillion law, which has now been allocated, we need to see how it's being spent and where are the remaining gaps. We also need to be looking at innovative ways to lower healthcare costs. Today, we're reviewing recycled language from 6 bills from the 2 from 2019 Energy and Commerce hearings. For example, the bill giving grants for state exchanges doesn't even update the date from January 1, 2019. So states like New Jersey that have already established an exchange since our last hearing could get funding from this grant. Additionally, I'm concerned with banning short-term limited duration plans. CBO has estimated that if the regulations are rolled back on these plans, 500,000 Americans would lose health care coverage. Instead of limiting plans, I think we need to allow states flexibility to best serve their residents. Of the 10 Medicaid bills, I specifically want to mention Money Follows the Person. This program is valuable for many individuals, and I am a champion of this program. Congress just extended MFP in December, which made important changes to the program. It is premature, in my opinion, to consider a permanent MFP extension before we know the impact of those changes. I also want to note that while the Democrats have called this hearing to talk about building on the Affordable Care Act, over 100 Democrats, including the chairman of this committee and 15 other members of this committee, introduced legislation that would ban ACA plans and Medicaid coverage and replace it with a one-size-fits-all government-run healthcare system for everyone. I'm concerned that innovation would stop fully under a government-run healthcare insurance program, and according to the Heritage Foundation, decrease the average annual American household disposable income by $5,600 or 11%. Let us not forget what we were told about the ACA. If you like your plan, you can keep it. Well, today we have bills before us that would do just the opposite, again, by limiting state flexibility and stopping short-term limited duration plans. But that would be nothing compared to the over 220 million Americans who would lose their health insurance under Medicare for All. I hope we will learn today about some of the unintended consequences of the legislation before us and change course to work together to come up with plans that will actually lower healthcare costs. America is not their government, should have the right to pick what health insurance and doctor is right for them. I thank you for the time, and I yield back.
The gentleman yields back. The chair now recognizes the chairman of the full committee, Mr. Pallone, for your 5 minutes for an opening statement.
Thank you, Chairwoman Eshoo. And this is a very important hearing. Today is the 11th anniversary of President Obama signing the Affordable Care Act into law. And the bottom line is, contrary to what our ranking member just said, is that the ACA has worked. many millions of people have health insurance now who would not have had it without the ACA. I'm amazed that with the Republican efforts to basically repeal it or basically cut it back, that it's still around. It shows its resiliency. It shows how people really want it, despite all the rhetoric on the Republican side that said that it, and particularly by President Trump, that said it should be abolished. But I do want to say in response to Mr. Guthrie that, look, we don't want to cut health care for the sake of lowering costs. My concern has always been that with these junk plans that do not provide essential services, people buy them thinking that they're going to have coverage when they don't. And so I would agree with you that when you provide, and I don't know if that's what you meant, but when you provide a lot of services, because our hallmark of the ACA has been that you have to have essential services, when you do that, it sometimes costs more. But the answer isn't to take a meat axe and say, well, we'll get rid of it and sell you a junk plan. I remember going before the Rules Committee, and I love Virginia Fox. She's a friend, but she basically said at one point that there were plans that were being sold that didn't include hospitalization, and that was okay if people wanted that. But to me, if you buy a plan that doesn't have hospitalization, you don't have health insurance coverage. So, keep in mind that the answer is to make things affordable, but not in a way that eliminates services like hospitalization and mental health and some of these other things that is what we get with the junk plans. In any case, earlier this month, Democrats and President Biden signed into law the American Rescue Plan, which is the largest expansion of healthcare coverage since the passage of the ACA, and that builds on the ACA so that healthcare is more affordable and more accessible for Americans at a time when they're struggling financially and when coverage is so essential. The new law expands the ACA's tax subsidies, including for the first time to Americans with incomes above 400% of the federal poverty line. Millions of Americans will gain healthcare coverage and see the cost of their monthly insurance premiums go down. Just as an example, a family of four with an annual income of $65,000 will save $2,800 each year. A family of four with an annual income of $100,000 will save $7,000 annually. And this is a huge benefit considering this family did not qualify for premium subsidies before the American Rescue Plan. It also provides an incentive for states, a new incentive for states to expand Medicaid by increasing the federal medical assistance percentage, or FMAP, of new expansion states by 5 percentage points for 2 years. And finally, the American Rescue Plan takes steps to address disparities in coverage that have been laid bare by the COVID pandemic by creating a new state option to provide continuous Medicaid eligibility for 12 months postpartum and provides billions in additional funding for home and community-based services, or HCBSs. Now, the 18 bills that we have before us today build on the accomplishments of the ACA and the American Rescue Plan and will make a real difference in people's lives. And these bills fix the 4 years of sabotage on our healthcare system from the previous Trump administration. We're going to talk about all these, but I just wanted to mention initially, because my time is going to run out, Representative Castor's bill that will require short-term plans to comply with the ACA's consumer protections and offer comprehensive coverage. Last year, our committee's investigation found that millions of Americans are enrolled in these short-term or junk plans that offer bare-bones coverage, discriminate against people with pre-existing conditions, and leave patients saddled with thousands of dollars in medical debt. These junk plans have no place in our healthcare system as they're structured today, and that's why we have to ensure they're required to comply with the ACA's consumer protection. I'm not going to go into the other bills, but I do want to stress again, we want to bring costs down, but we also don't want to allow people to buy coverage that doesn't include essential benefits like hospitalization, because without that, you don't really have healthcare coverage. And many people buy these junk plans and they're duped. They think it covers whatever condition they have, and then find out later that it doesn't when it's too late. So with that, Madam Chair, just thank you again. This is a very important hearing to say what we can do to make the ACA coverage even more expansive and less expensive in the long run. Thank you, Madam Chair.
The gentleman yields back. The chair now is pleased to recognize the ranking member of the full committee, Congresswoman Kathy McMorris Rodgers, for your 5 minutes for an opening statement.
Good morning, Madam Chair, and to all my colleagues, good morning. Mr. Guthrie discussed some of the concerns with the 18 bills before us, and I'm not going to talk further about those bills. These bills, unfortunately, divided Republicans and Democrats in 2019, and I'm disappointed that we continue to focus on what's dividing us. Instead, I want to talk about what we can accomplish in healthcare when we work together, and ask that we continue to build on our past bipartisan successes and lower healthcare costs I hear about every day from constituents in Eastern Washington. With the fast-paced, partisan, and polarized start to this year, I want to remind my colleague that this committee worked together to lower healthcare costs for the American people last Congress. The December omnibus and COVID relief bill was large, so you may have missed that it included the most significant legislation to reduce healthcare costs in over a decade. The December bill included solutions we worked together on to end surprise medical billing for patients, saving the government almost $20 billion in the process by lowering premiums. Provide long-term funding for public health, Medicare, and Medicaid programs, and we fully offset that spending. Improve transparency so employers who provide health insurance for their employees have a right to find out the cost of what they're buying. Support for rural and underserved areas by increasing funding and providing more flexibility for hospitals in those areas. Provide funding so that Medicaid enrollees with life-threatening conditions can participate in clinical trials. Address drug prices by requiring reporting to Health and Human Services and closing loopholes that may delay competition, and many more. There are more opportunities for us to work together and build on the great work of last Congress. We can work together to modernize the Medicare Part D program, to reduce what seniors pay for prescription drugs out of their own pocket. We could also examine the drivers of healthcare consolidation, which is contributing to ever increasing healthcare costs. I want to hear about how mental health and substance use disorder programs are working and how we can improve them, especially in light of the epidemics of despair made worse by COVID-19. We've also seen breakthrough innovation in the last year for COVID-19. Let's work together to find out what lessons we can take away from that and how to apply them to find cures for other diseases like ALS and Alzheimer's. Lastly, we must figure out how we can be better prepared against future pandemics. However, the bills today show us that the majority is choosing to go down a path for government-run healthcare rather than have these important discussions. Their end goal would include kicking every American off their health insurance plan of choice, whether it's employer-based, Medicare Advantage, or plans through labor unions. Americans would lose the few coverage choices they have left to make personal decisions about what is best for their families and be forced into a one-size-fits-all government-run healthcare program. Just last week, half the Democratic members of this committee introduced Medicare for All, including Chairman Pallone. We apparently will be having a hearing on that legislation at some point, according to the press reports. And the bills today continue us down the path towards socialized medicine that Obamacare started, expanding the use of federal taxpayer dollars to subsidize and removing patient choice by promoting the insurance the federal government thinks is best for you. My hope is that we can get to work in a bipartisan way soon to lower cost, increase transparency, address the mental health crisis, enable innovation, and prevent pandemics. Addressing just one of those issues would take months of work, but I stand ready and hopeful that we can get started on that in April. And I yield back.
The gentlewoman yields back. The chair would like to remind members that pursuant to committee rules, all members' written opening statements shall be made part of the record. I now would like to introduce our witnesses, and we're so fortunate to have each one of them with us today. First, Ms. Katie Keith, Associate Research Professor at Georgetown University. Welcome, and thank you to you. Mr. Dean Cameron, Director of the Idaho Department of Insurance. Welcome back to the subcommittee, Mr. Cameron. We're happy to see you and have you with us. Ms. Cindy Mann, partner at Manat, Phelps and Phillips and former director of the Center for Medicaid and CHIP Services. Ms. Marnie Jameson Carey, Executive Director, Association of Independent Doctors. Welcome to you and thank you for being with us. And Ms. Laura LeBrun Hatcher, Board Vice President of Little Lobbyists. Just really extraordinary advocates. So welcome to each one of you. Thank you for being with us. And Ms. Keith, you are now recognized for 5 minutes for your testimony. And please remember to unmute.
Thank you and good morning. Thank you to Chairwoman Eshoo, Ranking Member Guthrie, and members of the subcommittee. My name is Katie Keith, and I'm a faculty member at Georgetown University, where I study private health insurance. I'm also the author of the Following the ACA blog series for the journal Health Affairs, where I'm responsible for tracking and chronicling ongoing implementation of the Affordable Care Act. I'm especially honored to appear before you today on the 11th anniversary of the law, and mere weeks after enactment of the historic American Rescue Plan. The Affordable Care Act has already extended coverage to 20 million Americans, helped narrow racial and ethnic disparities in coverage, and served as a critical part of the safety net throughout the pandemic. We've seen enrollment through Medicaid and the marketplaces increase during the pandemic as demand has surged, and Congress leveraged existing Affordable Care Act standards to quickly mandate the coverage of COVID-19 testing and vaccines. On the law's 11th anniversary, it is more than safe to say that millions of families who would otherwise be uninsured have been able to enroll in Medicaid or the marketplace and get the coverage that they need for COVID-19 treatment, testing, and vaccines. Simply put, the Affordable Care Act has been there for millions of Americans when they needed it most. Enrollment is only expected to increase under the American Rescue Plan. As you all know, affordability has long been a challenge for many, even before the pandemic. This has been especially true for older, middle-income Americans living in rural areas where costs tend to be the highest. We all recognize that families who did not receive financial help before have had to make very difficult decisions, including remaining uninsured or enrolling in non-comprehensive coverage options. Sadly, the media has been filled with stories of families who enrolled in these non-comprehensive options only to be left with devastating medical bills when their plan did not cover the health care that they needed. Fortunately, the American Rescue Plan puts that behind us. The new law significantly increases financial help for lower income people and, for the first time ever, extends financial help to more middle-income Americans. Of the 14.9 million uninsured people who qualify for subsidies, 3.6 million of them are newly eligible based on their income. Savings will vary, but many middle-income people who purchase their own health insurance will soon see significant premium relief. The American Rescue Plan also helps with high deductibles that many consumers have struggled with in recent years. More people will be able to afford a plan that's much more generous than in the past, which means lower deductibles and lower out-of-pocket costs. Millions will be able to find a silver marketplace plan for $10 a month or less, or opt into more generous gold coverage with even higher cost-sharing protections. These reforms could not have come at a more important time given the pandemic. Americans across the political spectrum want Congress to lower patient healthcare costs and protect people with pre-existing conditions. The Affordable Care Act, as enhanced by the American Rescue Plan, does exactly that. And the legislation that you're considering today furthers those goals as well. The bills before you will increase awareness of this new financial help, will protect patients with pre-existing conditions from plans that discriminate against them, and will help states experiment to further expand access to coverage, to lower healthcare costs, and further advance health equity. In closing, health insurance has always been about access to health care and financial security. Under the Affordable Care Act and the American Rescue Plan, millions of families have access to affordable, comprehensive coverage and the financial security that having high-quality health insurance brings. The time is now to continue building on these important reforms. Thank you for the opportunity to address you, and I very much look forward to your questions.
Thank you very much for your important testimony. Next, Mr. Cameron, you are recognized for 5 minutes for your testimony. And as I said a few minutes ago, welcome back to the committee. Please unmute.
You bet. Thank you, Madam Chairwoman Eshoo. It's a pleasure to be back, and Ranking Member Guthrie and members of the subcommittee. My name is Dean Cameron. I am the director of the Idaho Department of Insurance. And thank you for this important hearing and this opportunity to testify and tell about Idaho's experience with the ACA and short-term plans in particular. I firmly believe that the solutions to health insurance will be found at the state laboratories of creativity. And I completely support each state's right to try different approaches that meet their individual state's needs. A fundamental tenet to all insurance is the spreading of risk, the ability to share risk with each other. Idahoans, like many other states, are being priced out of the marketplace, in spite of even this latest improvement to the APTC. The ACA has become too expensive, and many do not qualify or can avail themselves of the subsidy. These are people like teachers and spouses of teachers who, because of the family glitch, do not qualify, or ranchers or farmers who, because of their unpredictable income, cannot avail themselves of the subsidy. They want coverage, but they simply can't afford it. They're being forced to the unenviable position of either going without coverage or obtaining products such as those offered through health sharing ministries or short-term plans. As prices for ACA plans continue to rise, more and more citizens are forced out of coverage, especially the young and the healthy of all ages. And I can tell you story after story of older citizens who are being forced out of coverage. As more and more young and healthy citizens move out of coverage, prices continue to climb, then more leave, and the market is caught in a vicious cycle. Since 2015, Idaho consumers who are buying insurance on the individual market continues to decline. Now, this is at a time when our population growth is one of the highest in the country. The question before Idaho, and really before many states, was how do we provide quality yet affordable products to our citizens, and how do we improve the overall risk pool of the ACA? Or how do we attract the young and the healthy back into the ACA market? Given the existing parameters of the ACA, Idaho decided to restrict the traditional short-term plans to 6 months while creating another product, an enhanced short-term plan for those with coverage longer than 6 months, which has all of the essential health benefits as required by the ACA. In fact, of the 5 plans created in Idaho by 2 different carriers, 4 of them have better actuarial values than the bronze plans, and 2 of them have better actuarial values than silver plans. And if sold during open enrollment, are prohibited from pre-existing condition clauses. Additionally, these plans could only be offered by carriers that are currently in the exchange alongside of ACA plans, and most importantly, in the same risk pool. By requiring enhanced plans to be part of the ACA pool, we protect the ACA plans, and we lower the cost for those in the ACA marketplace, while attracting young and healthy back into the marketplace. Madam Chairwoman and members of the subcommittee, in my opinion, I would respectfully suggest the following regarding short-term plans. First, I would suggest to you that all STPs are not alike. Second, STPs are not junk insurance just because someone dubbed them as such. As I've said before, I have STPs in my state which are better quality than some of the ACA plans. Third, I would respectfully suggest that STPs fill a need for those who are in between jobs, those who are in between coverage, or in Idaho's case, those who cannot afford ACA plans. They act as a bridge between those who miss open enrollment until the next open enrollment. Fourth, and this is rarely acknowledged, STPs assist in early diagnosis and serious health conditions, which ultimately save money to the entire system. including ACA plans. Without this product, consumers will be forced to go uninsured, which will cost us more as their conditions go undiagnosed and untreated. Lastly, I would respectfully indicate for you that I believe passage of HR 1875 would harm thousands of Idahoans and hundreds of thousands of Americans, and would not, underline would not, benefit the ACA. In fact, passage of 1875, in my opinion, would potentially kick Americans off of their plan, increasing the number of uninsured, which would potentially lead to additional cost shifting and higher costs to those that are purchasing the ACA plans. Madam Chairman, I appreciate the opportunity to speak to you and would welcome questions and opportunity to speak on the other bills. Thank you, Madam Chairman.
Thank you, Mr. Cameron. Next, Ms. Mann, you are now recognized for 5 minutes for your testimony. And again, thank you for being with us today. And please unmute.
Thank you for inviting me today. It is a pleasure to be here, Chairman Eshoo and Ranking Member Guthrie. I'm Cindy Mann, and I am a partner with Manat Health, a division of Manat, Phelps and Phillips, and I do a lot of work with states and with hospitals, health systems, consumer organizations, foundations about delivery system payment reforms, and focus particularly on the Medicaid and the CHIP programs. Previously, before coming to Manat, I was a deputy administrator at CMS and the director of the Center for Medicaid and CHIP Services, and was there during the implementation of the Affordable Care Act. I appreciate the opportunity to testify today. Many important changes to Medicaid were, of course, ushered in by the Affordable Care Act, but the most prominent and far-reaching change is the one that sought to close a long-standing coverage gap in the program. Before the ACA, the public generally believed that Medicaid covered poor people, but in fact, until the ACA, Medicaid left out a large segment of poor adults. Who are they? Well, some of them are the children that Medicaid covers, but when they turn 18, in Medicaid parlance, they are considered childless adults. They are also the women who, when they become pregnant, they'll be covered by Medicaid, but before their pregnancy, they too are childless adults and were left out of coverage. And whatever their situations, most are working, many at multiple jobs, scraping by to pay rent and feed their families. The ACA didn't add a new group of strangers to the Medicaid program. It ended arbitrary coverage exclusions, and with the marketplace, created a continuum of coverage for those without access to affordable job-based coverage. As you've noted, Chairman Eshoo, the Supreme Court made the expansion voluntary with states, and not all states have taken up that really important option. In January 2014, when the coverage became effective from the ACA, we had 24 states that had expanded Medicaid. Today, 36 states do so. 2 additional states are poised to start coverage in July, leaving 12 states without expansion and over 4 million people without insurance as a result. After years of implementation, there is now a significant body of evidence on the success and impact of expansion. Before COVID, the expansion, since pre-COVID, the expansion covered about 12 million newly eligible people. Uninsurance rates dropped in all states, but the decline was particularly steep in the expansion states. 69% uninsurance rates in those states compared to 11.1% in the non-expansion states in 2019. But of course, it's not just about insurance, it's about the care, and studies have shown that people have gotten cancer treatments, preventive care, care management for chronic conditions. It's also helped people retain and gain jobs, and in the recession, it's really helped significantly cushion the blow for millions of workers who've lost their job. And notably, it has also reduced racial disparities in all states, and then particularly again in the expansion states compared to the non-expansion states. It's also helped the safety net. Rural hospitals, for example, have seen their uncompensated care costs drop by 43% in expansion states compared to 16% for rural hospitals in non-expansion states. And it's done most of this with little cost to states because of the generous match rate and offsetting savings. But the job isn't done. In my minute or so remaining, let me just review a few ways in which Medicaid coverage can be strengthened. First of all, closing the coverage gap remains, of course, key unfinished business. The added support for expansion in the recovery plan is welcome and so timely, given the public health emergency. I don't know if you've all seen the news, but just last night, an expansion bill passed in the House in the state of Wyoming. Doing a better job addressing racially driven inequities in coverage must also be front and center as we move forward. And again, the recovery plan took a really important step forward by extending the postpartum period of coverage for pregnant women. U.S. is, of course, is an outlier in terms of our share of Black women who are dying during or after giving birth, and postpartum coverage extension is a critically important advance. Equity issues, of course, are not just limited to discrete issues. They must be looked at in every part of our delivery system and payment system. We have a bill introduced by members of this committee which would create parity in payment rates for primary care between Medicaid and Medicare, and that would help quite a bit. Other reforms would also significantly improve coverage and care, including 12 months continuous coverage for adults and for children. And lastly, I want to note how important it is to give consideration to long-term services and supports, like those that are so important to Laura Hatcher's son, who's going to testify in a few minutes, her son Simon. Nearly a third of Medicaid expenditures are for home and community-based services or nursing home care. Medicaid is the default payer, and we need a number of reforms in that area. We need to reimagine long-term care so it provides safe and quality care for all who need it, preferably at home and in the community, and provides a living wage for those who provide the services. Serving more than 75 million people, nearly half of whom are children, Medicaid plays a central role in the healthcare system and in our communities. It deserves and it requires our support and attention. Thank you for allowing me to present testimony today, and I look forward to your questions.
Thank you, Ms. Mann. Next, we have Ms. Carey, who is recognized for 5 minutes for your testimony. Please unmute and know again how grateful we are for you to be with us today and your terrific work.
Thank you, Chairman Eshoo and Ranking Member Guthrie and members of the Subcommittee on Health. It's for the invitation to address you. It is truly a pleasure to be here on the anniversary of the Affordable Care Act. My name is Marnie Jameson Carey. I am the Executive Director of the Association of Independent Doctors, a national nonprofit trade association with members in 44 states. At AID, we work to educate lawmakers, employers, patients, and taxpayers about why preserving independent doctors is so essential to lowering the cost of healthcare, improving access, and restoring the doctor-patient relationship. Since AID was established, its mission has not changed. We strive to achieve system-wide price transparency, which would introduce competition into our price-opaque healthcare system. We aim to achieve site-neutral payments, so the same medical service costs the same, regardless of whether it's performed in an independent doctor's office or an outpatient hospital setting. And we work to stop the consolidation in healthcare, specifically the employment of physicians by hospitals and private equity groups, which drives up costs. I see the bills before this committee today as attempts to expand coverage and protect the vulnerable, which are certainly worthy causes. However, I would like to address a root problem, the fundamental reason so many Americans still lack coverage and access. Healthcare costs far too much. At nearly 18% of our nation's gross national product, Americans spend nearly 1 out of every $5 they earn to pay for healthcare. The system we have is driving prices higher. Since the ACA went into effect, national spending has gone from $2.6 trillion to over $3.7 trillion. Our lack of coverage and the issues surrounding coverage are a direct byproduct of the high cost of healthcare. If healthcare were affordable, coverage would begin to take care of itself. And the costs matter regardless of who's paying, regardless if it's the patient or the taxpayer or the government or the employer or the insurer. We can lower prices by achieving price transparency, realizing site-neutral payments, and stopping consolidation. Before I became executive director for AID, I worked as a health reporter, running for the Los Angeles Times and then the Orlando Sentinel. As the ACA rolled out, media reports were full of statistics about how many Americans would gain or lose coverage as a result of insurance exchanges, mandates, and Medicaid expansion. In fact, that remains much of the talk here today. Covered lives became the story largely because hospitals and insurers did a great job of turning the public's attention toward the issue of coverage and away from the matter of cost. Sadly, to some, cutting costs is less appealing than guaranteeing revenue streams. But lowering costs is where I'd like the subcommittee to focus today. The path forward begins with system-wide healthcare price transparency. For too long, hospitals and insurance companies have profited excessively from keeping their patients and prices in the dark. Most patients have no idea when they get their care what the price will be until they get their bill. This matters especially with those who have high deductible plans. However, if consumers could see the price of their care beforehand and shop and compare prices, more would choose lower priced providers. Price competition would enter the market and prices would come down fast. Patients would see the wide price variation. For instance, that the price of having a C-section at one hospital in California could cost $6,000 or $60,000, depending on their insurance. Price transparency would also expose facility fees, which hospitals tack onto their employed doctor services that add zero value, but that can drive up costs 3 to 5 times. As long as these prices are hidden, hospitals get away with these extra charges. When they no longer can, they will lose much of their financial incentive for hiring doctors. And when they do, we can slow, if not unwind, the consolidation trend in healthcare, which economists agree is a leading driver behind skyrocketing healthcare costs.
And I just want to mention that
Hello, sorry, am I still going here? We have made progress. In January, the Department of Health and Human Services hospital price transparency rule went into effect, requiring hospitals to show all their prices online. Only hospitals are not complying. Just yesterday, the Wall Street Journal published an article stating that their investigators visited over 3,000 hospital websites and found most had embedded codes that worked to block access to their newly posted prices. This is a golden moment for the Biden administration and for this Congress to build on the Price Transparency Initiative, which has its roots in the Affordable Care Act and which puts consumers in charge of their healthcare spending. A recent National Merit survey found that 91% of Americans believe that hospitals should be legally required to post all their prices online in an easy to access format. Price transparency is not a red or blue issue. It's an American issue. It's a unifying issue, and it would cost taxpayers nothing. As we acknowledge the anniversary of the Affordable Care Act and a new era in Washington, I urge the subcommittee to work to enact legislation that would reinforce system-wide price transparency, encourage competition, and discourage healthcare consolidation, all of which would drive down the cost of healthcare and make coverage truly accessible and affordable for all Americans. Thank you again for this opportunity and for your service to our country.
Thank you. And last but not least, Ms. Hatcher, you're recognized for 5 minutes, and please remember to unmute. Wonderful to have you with us.
Thank you so much. Greetings, Chairwoman Eshoo, Chairman Pallone, ranking members Rogers and Guthrie, and members of the committee. Thank you for inviting me here today to share my family story with you. My son Simon has the best laugh you've ever heard. He loves to watch the Muppets and play the drums, sometimes at the same time. Simon was born in 2006 before the Affordable Care Act became law. He had a brain bleed in utero, and when he was just 2 weeks old and in need of emergency brain surgery, I learned about the limitations of our private health insurance, about lifetime caps on care, and the danger of losing coverage because of pre-existing conditions my child was born with. Through Simon's early years, his diagnoses piled up: hydrocephalus, cerebral palsy, epilepsy, autism, a genetic disorder, and so did our medical bills, with each ride in an ambulance and each stay in the pediatric intensive care unit. My anxiety increased. I was afraid for my son, and I was afraid of losing his health insurance. I was terrified of reaching his rapidly approaching lifetime cap on care, and I had no idea what we would do when we hit it. So it felt like a miracle when the Affordable Care Act passed. I no longer had to worry about his health insurance dropping him because he needed a high level of care. And for the next 7 years, as Simon grew up, I grew more confident in my ability to care for my medically complex child, to get him what he needed to survive and to thrive. Then, in 2017, that confidence was shattered when the Republican-led House of Representatives voted to repeal the health care protection that my child's life depended upon. At first, I was devastated. And then I found other families like mine. Recall the Little Lobbyists, named after an article about a 6-year-old boy called Timmy, who came to Capitol Hill to ask Congress to save his health care. Simon and I joined Timmy, Ziamara, Abby, Emma, Joe, Teddy, Claire, and so many more amazing kids with complex medical needs and disabilities and their families. And together, we advocate for the healthcare, education, inclusion our families need to survive and thrive. And that's why I'm here today. Though there's still a case in the Supreme Court threatening the ACA, it seems that for now, ACA protections, which we worked so hard to save, have survived as our country begins to recover from this deadly pandemic and the horrific, disproportionate toll it's taken on marginalized communities, especially disabled, Black, Brown, and Indigenous peoples. It's time for us to work together to help all of our families thrive. So let me tell you a little bit more about my family. In 2019, after being on a waiting list for 9 years, Simon qualified for a Medicaid waiver thanks to Medicaid expansion in my state. We finally have coverage for the things that our insurance would not fully cover, like medication to prevent Simon's seizures, the pulse oximeter he needs to sleep safely, and the walker that he uses to get around. Simon also has access to home and community-based services. At 14, with the help of a direct support professional, he was able to get his first taste of independence. In addition to being Simon's mom, I'm a self-employed graphic designer. My husband, Brian, is also a designer. Recently, Brian lost his job, and with it, our employer-sponsored health insurance. But thanks to the Affordable Care Act and a navigator who helped us avoid treacherous junk insurance plans, we were able to purchase quality health coverage for our family through the exchanges. We've been able to turn an unforeseen hardship into an opportunity for Brian to join me in building our family business. But COVID has been tough on our business. Projects have been canceled or postponed, and it's also been tough on Simon. Online school has been hard, but he can't safely return to the classroom until he has access to a vaccine. He also lost his direct support professional because there wasn't enough funding for Medicaid services, for the PPE and support that his staff needed. Fortunately, Congress offered us a lifeline with the American Rescue Plan, and I want to personally thank you for that. You voted to support funding for Medicaid home and community-based services that people with disabilities like my son need to stay in their communities and out of deadly institutions. You voted to encourage states that have not yet expanded Medicaid to do so, so more people like Simon can access the life-saving care that they need. In addition to support for small businesses like mine, Congress built on the ACA. By expanding subsidies to eliminate the cliff that my family fell off of, I'm able to think about our future with the confidence of knowing that we will not pay more than 8.7% of our income on our health coverage, even if our business grows, as I really hope it does. I'm asking you to make these provisions permanent. My family and so many others need the security that comes with affordable, quality health care. Thanks to the ACA and to the American Rescue Plan, I'm able to sleep a little better and continue dreaming my American dream, where my family succeeds with a small business and my son with complex medical needs and disabilities survives and thrives in his community, in his country, where we all belong. Thank you.
Thank you very much. And thank you for all of the advocacy. It is really something to behold. And I think that if someone had said to you in the beginning, this is what you will be a part of, and that the organization would grow and be as effective, you would have said, no, we're not, never be able to do that, but you have. And it's been so important for so many. We'll now move to member questions, and the chair recognizes herself for 5 minutes for questions. You know, there's been a reference legitimately to what the American Rescue Plan and its subsidies, how they're going to benefit millions of people. I think that we have an issue here because the CBO estimates that only 10% of those uninsured and eligible for the new subsidies are going to enroll, and only 20% of those currently insured but unsubsidized will sign up for the new benefits because of a lack of awareness. So I think that whomever would like to take this, probably Cindy Mann or Katie Keith or both, what do you advise us and the administration to do? If people don't know, they're not going to take advantage of what we're working so hard to give them, you know, in terms of this coverage. My goal, the goal of so many, our North Star has been universal health care. And what we have in the American Rescue Plan, in my view, advances that. But people have to know. My other question is to Mr. Cameron. You are obviously a fan of the plans that you've spoken about, but you know, for these short-term plans, I have what really bothers me is that many of them are the king of surprise medical billing. The Congress addressed that, thank goodness, on a bipartisan basis, but they impose burdensome post-claim review processes to avoid paying for surgeries, for emergency room visits, for cancer treatments. They use the fine print of their coverage restrictions or enrollees' medical histories to deny claims. So there are problems with some of these short-term plans. And it's not to pick on anyone, it's to see what is wrong to be made right. And we had a hell of a time addressing surprise billing. And we did. It was costly and I think really wrong. So first to Cindy Mann and to Katie, Keith, what do you recommend that we do so that people will in fact take advantage of what we're working so hard to provide them? And Mr. Cameron, maybe you want to comment on the what I just outlined, and that 1875 closes the loophole that allows these short-term plans to avoid the ACA rules to finally put an end to pre-existing condition discrimination. You're talking about the ones that you like and do some of the good things, but that's not what is the case across the board. So let's start with, have a minute and 38 seconds for 3 people to answer my questions.
This is Cindy Mann. I'll jump in, but also be really quick. It's a really important point. The people have to know what the benefits are. People have to know what the rules are. People also need help applying. And we have had in the past very robust navigation and outreach efforts, but they dried up a lot over the last 4 years. The Biden
I didn't hear you. They what?
They dried up. They were cut substantially. And so this is a time, particularly because of the pandemic, where we need to increase that outreach and navigation. Your Covered California, the marketplace in California, has documented how important that marketing is to make sure people understand these rules and what's changed. Also, it's going to be really important to try and make those changes permanent so people will have confidence that they'll still be there. But
Mr. Cameron?
My colleagues.
Mr. Cameron, do you want to comment?
Certainly. I thought you had one other person in front of me, but to your question.
I only have 26 seconds now, so that's why I'm shifting.
First of all, I'm a fan of choice. I'm not necessarily a fan of all STP plans, and I will tell you that many states have adopted regulations that are trying to address the issues with the bad actors. Like in everything, there are bad actors and there are good actors, and we have addressed those. We have limited pre-existing condition clauses for all of the plans. They have the same, in some cases, the same approach or clauses as the ACA plan. We go after them in the fine print, and we help consumers be able to get the coverage that they need. I would also just quickly say that many of those that will not take advantage of the subsidy that you mentioned are those that are healthy and the plans are still too expensive.
All right, my time has expired. I now will recognize the ranking member of our subcommittee, Mr. Guthrie, for his 5 minutes of questions.
Thanks, Chair Issue. I appreciate that very much. Ms. Carey, I guess what we're talking about where the Affordable Care Act hasn't been successful is in controlling costs of healthcare. As you mentioned, over $1 trillion have increased in healthcare spending since the Affordable Care Act was passed 11 years ago. And testimonies has been given today that the ACA and we hear American Rescue Plan has made coverage affordable by subsidizing ever-increasing costs. And this continued increasing subsidies to chase ever-increasing costs is just not sustainable, and particularly those who are just above the threshold to get any kind of subsidies continue to get squeezed by the ever-increasing costs. So my point is that we have failed at controlling healthcare costs or getting a handle on healthcare costs, and we need to focus on healthcare costs or the system's going to implode. And so your research, Ms. Carey, has been on government and the federal government and its role in driving healthcare costs, particularly structure and regulations of Medicare. Could you explain further? I know you did in your opening statement, but could you explain further how we can deal with healthcare costs, which would hopefully make insurance, if we deal with the costs, it makes insurance more affordable. We're going to make insurance just unaffordable for everybody if we don't deal with costs.
That's right. We all pay for healthcare, whether we're paying as the patient or paying as a taxpayer or paying through premiums. So we have to bring down the whole burden across the board. And there are many systems in place right now that are working to drive up the costs. And hospitals, when they purchase medical groups, they are able to layer in facility fees that independent doctors don't charge. And that compounds. So if you have a primary care doctor who refers you to an orthopedist, refers you to an MRI, refers you to an outpatient surgical center, all of them layer in facility fees, which drive up the cost of care five times or more. So we need to unwind that and bring those costs down and make them expose them through price transparency. When patients begin to see the huge variance in price, and that you can get a colonoscopy for $750 and across the street for $4,000, and you look for the quality and you get the best value, competition will enter the system and the cost will come down, and that will take care of itself.
Thank you for that. And Ms. Mann, in GAO's report on express lane eligibility, ELE, GAO found that CMS has issued guidance on how to determine ELE errors and calculate such payments if those errors occur. If the ELE option is continued, it will be particularly important that CMS issue such guidance, as questions have been raised by states and others regarding how ELE error should be defined. Has CMS issued such guidance?
There's a lot of guidance, Congressman, around error rates and how those are calculated. So some of that guidance would pertain to the express lane eligibility that you speak of. It's only a couple handfuls of states, about 9 states that do express lane eligibility. And both the GAO and OIG found that it's been an effective program, albeit a limited scope program to be able to promote enrollment and retention. But certainly CMS can continue to look at questions around it and issue guidance as needed.
So more guidance is needed, as it appears?
Well, the findings from the OIG and from the GAO did suggest that there be more guidance. OIG indicated that it didn't see any particular evidence of erroneous determinations. That was a while ago. Those reports were several years ago. So it's always good for CMS to continue to look at all facets of the program and identify whether any particular additional guidance is needed to assure program integrity.
Hey, thank you very much for that. And Mr. Cameron, I know Idaho is one of 27 states with short-term plans, and short-term plans aren't for everyone. They're typically are a gap when people need coverage and they need affordability. So just would you talk, I have 40 seconds left, about states' the ability to regulate these plans and who these plans are valued for? They have value for certain groups of people.
Absolutely. Certainly they have value for those that are in between jobs or those that are forced out until the next open enrollment period. Many states have also started regulating these plans a little more intently. Some states, 5 states have banned them. 20 states have limited what these plans can have in them, limited their length of time, and even those that allowed, like Idaho, to allow them to exist longer than 6 months, have instituted requirements on pre-existing conditions and on essential health benefits. We're really trying to attract the young and the healthy back into the marketplace so that we'll help hold down costs for everyone, including those that are buying coverage through the ACA.
Thank you. My time's expired and I yield back. Thank you, Madam Chair.
The gentleman yields back. Pleasure to recognize the chairman of the full committee, Mr. Pallone, for your 5 minutes of questions.
Thank you, Chairwoman Eshoo. You know, it bothers me because we keep hearing about this idea of choice. And of course, you know, you don't have to choose the Affordable Care Act. You don't even have to have health insurance at all if you don't want to. So you ultimately have a choice of what you want to do. But I think that what bothers me is that, you know, you say you have a choice, but when you buy these junk plans, people don't realize that they don't cover things. And so, you know, I use the extreme example, which was sold before the ACA. I don't know if it's sold anymore, where people would buy plans that didn't have hospitalization. They go to the hospital and then they're shocked to find out it doesn't cover hospitalization because they can't believe a plan is sold that doesn't cover hospitalization. Nobody believes that when they buy a plan, it's not going to, you know, cover mental health. It's not going to cover maternal health. They just assume it does. And you can say, well, they're stupid and that's their own problem. But, you know, this is the reality that you can't have these false choices. The same thing is with innovation. Of course, we're all for innovation and we want to encourage innovation, but everybody wants the new thing. They want the new machine. They want the new way of diagnostic care. Well, a lot of times those things drive up the cost, but everybody wants them. And so I kind of want to debunk this thing that you can squeeze a lot more out of the system and still do more. I don't really think that's true. If you squeeze the system, often what happens is you don't have benefits, you don't have new techniques, you're not covered. And, you know, it may be that you can squeeze a little more out of the system and save money, but that's often not the case. So with that, I really want to go to Ms. Keith. I want to ask you about these short-term or junk plans with the 3 minutes we have left. These junk plans often exclude coverage for prescription drugs, mental health, substance use disorder, and in some cases, basic preventative services. Is that correct?
That is correct, yes.
And I understand that these junk plans impose annual and lifetime limits. Is that correct?
That is correct.
And is it correct that these junk plans also deny coverage altogether for individuals sometimes with pre-existing conditions?
That is correct, yes.
So my Republican colleagues claim that these short-term or junk plans provide Americans with choice. That's what I mentioned. But is this choice to buy bare bones coverage beneficial for consumers? Can you describe why an individual who's healthy when they sign up for one of these plans can still be subject to hundreds of thousands in medical bills?
Thank you for that question. So there's many reasons why someone who might be healthy enrolls and then comes to need healthcare. They might have an accident, they might be injured, they might get pregnant, they might be diagnosed with something. And when you happen to be enrolled in one of these short-term plans or other non-comprehensive options, you end up with high medical bills because of the significant gaps in these products. They simply don't cover the benefit categories that you just mentioned that most people expect to be covered. Prescription drugs is a huge one. They often have very high out-of-pocket costs, so up to $30,000. That's compared to about $8,000 with Affordable Care Act plans. And many exclude coverage for pre-existing conditions in addition to the other benefits and services that they often exclude. Those are just some of the ways that I think enrollees in short-term plans can be very surprised and end up with devastating medical bills as a result.
And Ms. Keith, our committee did an investigation and they found that these short-term or junk plans subject consumers to invasive and burdensome process to avoid paying for medical claims. And consumers are denied coverage for life-saving and necessary treatment and left with thousands of dollars in medical bills. You see, the problem is, you know, you can talk about choice and you can say, oh, everybody should have a choice. But unfortunately, a lot of people just don't understand when they sign up for these things. You know, no one would ever believe that they have health insurance that doesn't cover hospitalization. Most people would never believe that they have health insurance that doesn't cover maternal health care, right? I mean, who would think that you would sell that kind of a plan? And this is my experience. This is what happens. And this is what the committee found, that oftentimes, and then what happens is the plans try to get around all this and people end up bankrupt. And, you know, I just want to stress that because I think it's so important, this, you know, because I know you could always say, look, it doesn't matter, you know, people, you know, buyer beware, but they don't read the fine print when they sign up. They're just not aware. So thank you again. I appreciate it. And with that, Madam Chair, I yield back.
The gentleman yields back. Chair recognizes the ranking member of the full committee, Mrs. Rogers, for your 5 minutes of questions.
Thank you, Madam Chair. Thank you all the witnesses for being here. You know, across the country, states run their own exchanges. And we've seen in those state-run exchanges an enrollment increase for the most part, although Washington State has actually seen a decline both in 2019 and 2020. And it highlights the need for more affordable options. So Mr. Cameron, my neighbor, my district actually borders Idaho. I was excited to learn about the innovative model that you've come up with in Idaho. And you've clearly worked very hard to try to find the options that people need so that they have health insurance and they have access to that health care when they need it. I'd like to start out by just asking you, what advice do you have for us as we are continuing to try to make healthcare affordable? And in your opinion, is there anything stopping Washington from implementing a plan like yours?
Well, thank you, Congressman, and thank you for the compliment, and I'm glad to be here. First of all, our plan, our approach could be adopted by other states, provided some of the bills that are introduced today don't pass, which really cut the legs out of anybody buying a plan, regardless of whether it's a good plan or a bad plan, if it's outside of the ACA. You know, the implication that you're somehow better without coverage than you would be with coverage that is inferior is, I just don't agree with that. And we've worked long and hard in Idaho and many other states to try and put appropriate standards and guidelines around what should be short-term plans and to avoid the fine print.
Okay,
I guess
thank you.
Oh, sorry.
Thank you. I want to move on to a couple other questions too. Just do any of the bills before the committee today, in your opinion, lower the cost of healthcare?
You know, the only bill that I think is in front of the committee that has even a remote chance is the one that funds reinsurance pools, but then only if it's modified and adjusts to do high-risk reinsurance pools that are invisible reinsurance pools.
Okay, thank you. Ms. Carey, do you believe any of these bills before the committee will help lower the cost of healthcare?
I didn't see any evidence of that.
Okay. You know, I really think that this hearing is a missed opportunity to build on our work together to actually try to lower the cost of healthcare, not to shift those costs to the taxpayer. I'm excited about the potential of transparency to lower cost, but I'd also like to hear about how it would help patients. Ms. Carey, can you give us some examples of how transparency within healthcare would help patients pay less for their healthcare?
Oh, it would help in so many ways. First of all, it would put the power in the patient's hands and not into the insurer's hands and the government's hands. It would help them drive as consumers, improve every market. When they have price competition and price transparency, markets compete, quality gets better, and prices come down. We've seen it in retail, we've seen it in airlines, and if consumers can get on their phone an app that compares what it's like to have a hernia surgery or how much it costs across system-wide, and they pick the high-value, low-cost provider, others are going to have to compete, and that's going to empower patients, bring costs down, and really make healthcare affordable and accessible.
So as a follow-up, what advice would you have for a patient needing to get an MRI, for example, that has a high deductible?
I would go to any place that posts their prices. Green Imaging has price transparency as an imaging center across the country. Go to a surgical center like Oklahoma Surgery Center and look up what they charge for a knee replacement, for example, is $15,500, where the average cost for a total knee replacement is $57,000 in this country. And you go to your hospital and you say, look, I can get an MRI for $350 over here. I can get my knee replaced for $15,500 over here. Can you match that? That's what I would tell the American consumer, to hold the hospitals accountable to the price that you should be paying, not that the prices that they want to charge you.
Would you speak to the concern about quality as you're making that decision?
Quality of care also takes care of itself when patients have transparency into the marketplace. A great example is LASIK surgery, which has only come down in price because these ophthalmologists are competing and the quality is being reported online in real time. The same with plastic surgeons, who typically don't get involved with insurance. They get private pay and their prices come down and their quality has gone up. It works in the market and it can work system-wide.
Thank you. I appreciate you being with us today.
My
I yield
pleasure.
back, Madam Chair.
The gentlewoman yields back. Pleasure to recognize the gentleman from North Carolina, Mr. Butterfield.
Thank you very much,
Sure.
Madam Chair. It's good to see all of you this morning, and thank you actually this afternoon now. But it's also good to see the witnesses, and thank you for your testimony. Let me spend my few minutes with Cindy Mann, if I may. Ms. Mann, just 12 states, including my home state of North Carolina, have failed to expand Medicaid. We've talked about this now for 11 years. They have failed to expand Medicaid despite the federal government picking up the majority of the cost. The American Rescue Plan included a robust financial incentive for these states. States that expand under this new incentive can use those funds to combat the pandemic. They can expand coverage. They can bolster their programs. For example, it would cost North Carolina $490 million to expand the Medicaid program. But North Carolina would receive $1.7 billion in new federal funding if it expanded under the American Rescue Plan. Do the math. North Carolina could reinvest the remaining $1.2 billion of new federal funds in critical state programs and in communities like I represent. The question is, I believe the states like my state should expand Medicaid because it's the right thing to do. I believe that 600,000 North Carolinians who would gain coverage and access to quality health care under expansions are reasons enough. But Republicans who control our state legislature have thus far agreed with me. Disagreed with me. Given that, can you discuss the economic benefits of Medicaid expansion for states and communities? We've heard it before, but we need to hear it again.
I'd be glad to. Thank you for the question and thank you for your support for getting expansion in place in North Carolina. It is represents about 10% of all of the people in this country that are in the coverage gap, and your residents in North Carolina. And you're absolutely right, Congressman. It's a real value fiscally to states. There's been an increase certainly in Medicaid expenditures as a result of the expansions, but it's been because we've been covering more people, and the vast majority of those additional costs have been borne by the federal government. States have enjoyed a generous match rate, and they've also been able to offset other costs that they've been spending with state-only dollars with the value of having a Medicaid matching apply. So it's been enormously helpful to states. I need to remind everybody, of course, that we have Medicaid expansion in 36 states. There are states with Republican legislators and Democratic legislatures, Republican governors and Democratic governors. No state that has adopted an expansion has decided to drop it. And that's, of course, in part because it's been providing care for their residents. It's providing reduction in uncompensated care for providers who serve them, but also because it's been a real benefit fiscally for states to be able to provide that care and bring in federal dollars to share in the cost.
You talk about these expansion states and how they've benefited can you give me just a very simple, plain example of how expansion can benefit the state other than providing care to the patient and improving the economy? Are there some other collateral benefits?
Sure. So let me mention a couple. One is virtually every state right now, expansion or non-expansion, they'll spend some of their own dollars, whether it's on mental health services, substance use disorder services, they're spending state-only dollars. And yet with a Medicaid expansion having a much broader group of beneficiaries who can now enroll in the Medicaid program, that brings in federal dollars where the state has been shouldering those expenses with state-only dollars. Medicaid has been an incredibly strong factor in terms of addressing the opioid crisis, for example, bringing down deaths and destruction in communities across the country. The other way in which Medicaid provides fiscal benefits to states is because the federal dollars coming in provide additional economic activity in the state. And so there's a boon in that way as well. And for some states where they have imposed fees on health providers or health plans, often those fees are based on how many lives are covered. So to the extent that plans or hospitals are serving more people, they may be paying more revenues into the state.
Thank you. Thank you, Ms. Mann, and I pray that we see the day very soon when these 12 states will expand Medicaid.
I'm hopeful. It's a very exciting incentive that you all have made available. And
thank you. I yield back, Madam Chair.
The gentleman yields back. There is hope on the horizon. I mean, two deeply red states, Wyoming and Alabama, are considering expansion. So there's hope out there. There's a movement. The chair now recognizes Dr. Burgess. Are you there, Dr. Burgess? I don't see you. Not there. We'll circle back to him, and I'll recognize the gentleman from Virginia, Mr. Griffith, for his 5 minutes of questions.
Thank you very much, Madam Chair. I go to Ms. Jamison. I instinctively like what you are saying about transparency, but there are hospitals who say that they would have a hard time being able to stay open in rural areas if the transparency that you propose is mandated. What's your response to that argument?
Well, we need hospitals and we need them to stay open, but we don't need them owning all the physicians in a community and all the imaging centers. And we need them to unwind themselves of some of the consolidation and focus on their internal hospitalization needs. So I find a lot of hospitals spending a lot of money that they are not paying in property taxes, for instance, because 62% of our hospitals are non-for-profit or they pay no taxes. This money is supposed to get plowed back into the community in the way of charitable patient care, but instead they're turning it into infrastructure. So I'd like to see a little realignment of the funds, have them spending less money on acquiring things, less money on building things, and more on giving back to the patient and getting their costs truly in line with delivering patient care.
I look forward to figuring out how we get that balance down, because I am worried about our rural hospitals as well. But I want people to know that you can lower costs on things like eye surgery. You mentioned LASIK. And when I was in the state legislature, I worked with a group that was working on cataract, a standalone surgical center for cataracts and glaucoma, that as soon as they got the permission to open, the prices in the community dropped substantially at all providers, including the hospital. All right, Mr. Cameron, does Idaho have a network adequacy? Does Idaho have network adequacy standards to ensure health plans in your state provide sufficient in-network access to primary and specialty providers?
Yes, we do. We have 6 carriers in our exchange, which is not, most other states can't brag of that. And we do have network adequacy standards that we require that they meet.
And how do you balance network adequacy with insurers' ability to negotiate lower costs or exclude lower caliber providers?
Well, obviously they have the ability to establish those contracts. As seen, at times it requires a negotiation and conversation with our department and the provider, or our department and the insurance carrier, to make sure that it's taken place.
do you think folks at CMS in Baltimore or Washington, D.C. would understand the nuances of Idaho's health insurance market to be able to write rules addressing your network adequacy standards?
Absolutely not.
And how about your rate review determinations? And explain if you can.
Yeah, we have a very extensive process in which the carriers are required to submit their rates. We review every policy, every wording of every policy, and we review how they calculated the rates. We have actuaries on staff that review them, and we push back at times. We have a high-risk reinsurance pool that helps us, and we argue that rates should be lower because of that. And so we've done a pretty good job over the last 4 years of trying to control those rates, in spite that their costs, particularly 5 years ago, were being really exorbitant.
What do you think the confusion caused by perhaps having folks at CMS in Baltimore, Washington, trying to make all these rules and decisions? What do you think that confusion would do to competition? And would it encourage or discourage insurance carriers to offer plans in Idaho?
Yeah, we think it would discourage them. We think it would create I don't know what the right word is, a vacuum where carriers would not be able to offer and meet those demands. We think consumers would be less protected and would not know who to turn to. So when we hear about folks that have bought plans that are not appropriate, we hear those on ACA plans. We hear that we get complaints all the time on folks that have bought ACA plans and they thought something was covered and it wasn't. And if they had to report to Washington, that would be devastating to them.
If Medicare for All that was introduced last week were to pass, the bill would eliminate Medicaid as well as the private market. Approximately how many people in your state would lose their current insurance plans? You know?
It would be about 1.4 million, which would lose their coverage, which is about what we have covered. We have 1.8 million is our population.
All right. Thank you very much. I yield back, Madam Chair.
The gentleman yields back. Pleasure to recognize the gentlewoman from California, Ms. Matsui.
Thank you very much. Thank you, you too. Thank you very much, Madam Chair, for calling this very important hearing. And a happy anniversary too for ACA. From the young and uninsured to the middle income off-exchange couple, an estimated 25 million Americans stand to benefit from the health coverage expansions in the American Rescue Plan. However, as the chairwoman outlined, the Congressional Budget Office estimates that only a small percentage of the uninsured or unsubsidized, some subsidized, will sign up for the new benefits. Ms. Keith, Covered California is encouraging its 11 health carriers to invest in marketing and outreach to find off-exchange consumers, to let them know that they are now eligible for financial help. Is this something that the Biden administration could do as well?
Thank you, Congresswoman, for that question. So I would first say that I think the CBO's estimates are low on this point, in part because these enhancements are only temporary. So if and when those enhancements are made permanent, I think we would see those numbers increase significantly. So I do want to make that point. In terms of what Covered California is doing, I think Covered California has really led the way in investments in marketing and outreach, and they've put together entire reports about how that's helped keep premiums down in their state and really brought in younger and healthier people. So far, the Biden administration has allocated about $50 million to advertise the current special enrollment period that's running through healthcare.gov. I think an even greater investment is needed, and certainly I think to undo some of the harm that we've seen over the past 4 years. Many uninsured people are unaware of the Affordable Care Act. I think the same is going to be true of this new financial help that's available, and I think it's on all of us to make sure that people understand their options.
Well, thank you very much. And on California, we really built a plan to maximize enrollment and based upon marketing principles. So we hope to encourage the administration to do the same too. From PPE and testing to treatment and vaccinations, inequitable access has been really a defining characteristic of the COVID-19 pandemic and an enduring problem in America's healthcare system. The ACA's Medicaid expansion helped reduce longstanding racial disparities in health coverage, but we know that coverage alone is not enough to eliminate these disparities. This is one reason why the American Rescue Plan injects new resources to states, localities, and directly to families. Ms. Mann, can you provide an example of how some states are working to address social determinants through their Medicaid programs?
Certainly, and thank you for that question. Let me start with your home state, was the state of California, which has been operating under a Medicaid waiver and has had something in place in pilots around the state called whole person pilots,
Yes.
whole person care pilots that have invested in social determinants of care, have addressed homelessness, has addressed housing insecurity issues, has addressed hunger and violence and other needs that people have. And they are now looking, the state of California is now looking to make that program statewide and to really make sure that whole care is provided, meaning that we don't release people from a hospital if they're homeless. That's not good care. That's not smart care. That's not cost-effective care. So increasingly, we're seeing states do that. North Carolina is a state that has just about to embark on major system transformation in its Medicaid program, where buying health is the mantra. And that buying health means excellent medical care, but also really thinking about those health-related issues that can drive bad health and healthcare costs. So we've seen an enormous number of states really move ahead, particularly in COVID times, realizing the link between social drivers of health and delivery of healthcare is so important if we're going to get good results.
So you would recommend that Congress support these type of programs moving forward?
I think it's really important to support it, and there's a number of ways they can be supported. Part of it is in our healthcare system itself, making sure that payers, Medicaid, Medicare, commercial payers recognize some of these services, but also we need other investments. We need more affordable housing.
Right.
The investments in that increase SNAP benefits are all important ingredients to really making sure that that the whole person is cared for and that people actually can get healthier as they move through the system.
Well, thank you very much, and I agree with you, and I yield back.
Thank you.
Gentlewoman yields back. Pleasure to recognize the gentleman from Florida, Mr. Bilirakis, for your 5 minutes of questions.
Thank you, Madam Chair. Appreciate it very much. Thanks for holding this hearing. First question is for Mr. Cameron. One of the major promises of the ACA was affordable insurance for every American. The law even went so far as to penalize those who did not enroll. However, in the decades since its enactment, insurance costs continue to rise. Why is that?
Well, I think it's a number of reasons. Thank you for the question. It's because those that are healthy are pushed out. Those that don't qualify for a subsidy are forced out. So if you're a school teacher and your employer offers you coverage, but it doesn't pay for the coverage on your spouse and your kids, you don't get a subsidy. If you're a rancher or a farmer, you don't qualify for a subsidy because your incomes are too unpredictable. All of those things, that family glitch and the unpredictable nature has forced the young and the healthy out while costs have continued to rise. And so what you have in our marketplace, what we have essentially is those people who absolutely need coverage or who are subsidized. About 85% of our folks, maybe even 90% of our folks receive a subsidy, and it has to be a significant subsidy. If it's just a $50 subsidy on a $1,000 premium, it doesn't get people to buy.
Thank you. Second question for you, sir. CMS released a report in August of 2019 on individual insurance market enrollment trends. Data shows that between the years 2016 and 2018, unsubsidized enrollment declined by approximately 40%. If the ACA has fulfilled its promise to provide affordable health coverage to all, why has this decline occurred? And is it an absolute affordability issue? And if so, How has Idaho, your state of Idaho, responded to increased enrollment and its risk pool?
Yeah, thank you very much for the question. First of all, it absolutely has happened. We've seen it happen in our state, and essentially people are being forced out of the marketplace. They're unable to afford those prices. And so if you aren't getting a subsidy, you don't have any choice. Your choices are going without coverage, or going to a health sharing ministry plan, or going to a short-term plan. And so what we did in Idaho is we said, okay, if this is where people are being driven, how do we improve the marketplace? How do we help the ACA plans? And so we said, okay, if you're going to offer long range, short-term plans, you have to meet the conditions of short-term plan of the ACA. You have to have all the essential health benefits. You have to not have pre-existing condition clauses if you're selling at the same time on the exchange. And you have to allow, be part of the same risk pool. So we tie the rates together. So if the rate increases occur to one, it occurs to both of them. So they are all sharing the same risk pool. And in my mind, that's what the ACA was intended to do, was to do that. But then the rules and subsequent decisions have forced individuals out, have made prices higher. And so if you're not getting a subsidy, if you are in that family glitch, we're not getting the benefit of you being in the risk pool.
Thank you very much. Next question for Ms. Carey. How are hospitals complying with the price transparency rule issued by the previous administration? I think you addressed that. Where do the biggest issues persist in achieving true transparency, and how can Congress address this?
Thank you, Congressman, for the question. Congress can address this by putting a law in place that further reinforces the rule and going further in requiring hospitals to show not only their discounted cash prices, but all their secret negotiated rates with all their contracted payers. And insurance companies are supposed to follow a rule that lands January 1, 2022. We need Congress to make sure, and HHS to make sure, these rules get put in place and get recognized and are enforced. Hospitals are not complying with the rule as it stands. We've seen a lot of good investigative media coverage exposing that. They really need to be held accountable. We really need machine readable format so data innovators can aggregate the data. We can start to shop for prices the way we shop for airline tickets, and the competition will kick in and the prices will come down.
Thank you. And Madam Chair, in the interest of time, I'll go ahead and yield back the rest of my time.
The gentleman yields back. Pleasure to recognize the gentlewoman from Florida, Ms. Castor, for your 5 minutes of questions.
Well, thank you, Madam Chair. Thanks for having this very important hearing on how we expand coverage and lower healthcare costs, including two of my bills. But first, happy 11-year anniversary to the Affordable Care Act. It has provided affordable comprehensive health coverage for families, and on behalf of the over 2 million Floridians who go shopping in the healthcare marketplace, and that's where they get their affordable coverage. Thank you. Thank you on behalf of the seniors in Florida who have stronger Medicare. Thanks on behalf of all of the young people who have been able to stay on their parents' insurance. And by the way, when you're talking about choice, here in the Tampa Bay area, if you go shopping in the ACA marketplace, there are over 100 private plans that you have to choose from. So I think that highlights the importance of Navigators. But now, thanks colleagues in the American Rescue Plan, we have made ACA coverage even more affordable. One estimate in the Sunshine State is we have over 300,000 families that are newly eligible for expanded tax credits. So that's going to make a real difference. And of course, we still have the issue of expanding Medicaid in Florida. If we were to do that, not only will we bring billions of dollars of our tax money back to the state and expand economic activity, as Cindy Mann has said, but this would make a real difference in the lives of so many Floridians. So hopefully they will hear what Congressman Butterfield said. Do the math. This is a benefit, and I want to thank Rep. Veazey, who's worked on this with me and his terrific Incentivizing Medicaid Expansion Act, and Rep. Schreier, Dr. Schreier, thank you for your work on the kids' access to primary care that'll boost the Medicaid
reimbursement rates as well. But I want to spend my time on Navigators and these outrageous junk plans. One of my bills is the Expand Navigators Resources for Outreach, Learning, and Longevity Act, or the ENROLL Act. It will provide continuity for families and navigators. And I'd like to ask Ms. Hatcher, first of all, you said that you used a navigator to help you shop for coverage in the ACA marketplace. How did the navigator help you find coverage that was right for your family?
Thank you for the question. The navigator was actually quite indispensable. Shopping for healthcare is overwhelming under the best circumstances. There's lots of different options, and trying to figure out what will be the right fit for your family is a challenge, especially when you don't have the backing of an HR department. So the navigator kind of functions as your own HR professional. She or he lets you know what your options are. You can talk through different plans. They help you just determine what your subsidies may or may not be. So it's been truly indispensable. And they also help you be sure that the coverage that you think you're getting is what you're getting. What we learned through the ACA is that we were actually able to purchase better insurance than what had been offered through my husband's employer-sponsored care. We had more options. We were able to choose a plan with a company that we trusted. And it was actually a very, very good experience, very positive.
Thank you. Now on junk plans, Ms. Keith, thank you for your outstanding testimony. I'm so concerned about these junk plans and the fact that so many of these companies take advantage of our neighbors. In fact, I just got word this morning when I was asking for that update on how many plans in this local area. They shared a story that just last week, a couple was dropped without notice. They had one of these junk plans that dropped without notice. They did not find out about this until they went for a CAT scan. They didn't have coverage because this short-term plan, they hightailed it out of there and they had to pay out of pocket for the CAT scan. And we just can't suffer. We can't have folks suffering like this anymore. We know that a lot of these plans have these fraudulent marketing tactics too, but talk to us about some of the back end tactics that these plans engage in to avoid paying medical bills.
Yeah, thank you for that very important question. So some of the back end tactics, many of these companies engage in what we call rescissions. So as soon as someone actually needs healthcare, and maybe this applies to the couple that you're talking about in Florida, as soon as they need healthcare, the insurance company will pull their application, will ask for medical records going back 3, 5, 7 years, and comb through all of that information, looking for a reason to tie the healthcare that they need either to a pre-existing condition or some reason why they shouldn't have issued the policy in the first place. That gives the company grounds to pull back, to rescind, to cancel the policy, leaving the person without any type of coverage at all and fully responsible for their medical bills. It's one of the biggest abuses that we've seen.
Right, your time has expired.
Thank you.
Your time has expired. Thank you, Ms. Castor. The chair is pleased to recognize the gentleman from Missouri, Mr. Long, for your 5 minutes of questions.
Thank you, Madam Chair. And I hate to go over plowed ground, but whenever the ACA was about to come into effect, we had discussions about the navigators. And if memory serves, you could not be a navigator if you knew anything about insurance. If you had any nexus to insurance, you were disqualified for being a navigator. So to me, that was kind of like if your car needs a repair, you can take it to anyone but an automobile mechanic. So with that being said, Director Cameron, here's my questions for you. You talk about the importance of getting people into the marketplace to stabilize and lower premiums. The ACA Navigator program has consistently underperformed in its enrollment goal. In 2017 and 2018, Navigators enrolled only 1% of total enrollees and had comparable outcomes for 2018 and 2019. Agents and brokers, which are licensed and trained to educate people on insurance, can be much more effective and cost efficient in assisting people obtaining coverage. CMS noted that in 2018, agents and brokers were responsible for 42% of enrollees at an average cost of $2.40 per enrollee. Can you discuss how effective the Navigator program has been? And do you think we should be providing an additional $100 million for the program collected from exchange user fees?
Thank you, Congressman, for that question. No, I do not. In our state, we have used some navigators, but the bulk, about 80% of our folks that enroll use an agent who actually is, as you said, licensed and trained. They have to go through an extra training program to work through our state-based exchange, so that we make sure that they are covering all of the facets appropriately. And that's how the majority of Idaho citizens obtain their individual coverage. And frankly, that's the safest. That's the safest way. They are responsible for what they helped individuals purchase. And so we think rather than spend that money that way, that it'd be better to more embrace the agent community and the agent population.
Do you think navigators should be able to consider short-term limited duration plans when assisting potential enrollees?
I don't believe a navigator would have the expertise to be able to distinguish between a good short-term plan and one that maybe is not as good. So I would have some heartburn with that. Obviously, if they became licensed and were trained, even though they're operating as a navigator, but if they're licensed and have all of the same similar training as an agent, then perhaps they could.
What are some of the headwinds and challenges that agents and brokers in your state face helping people obtain coverage in the ACA marketplace?
Yeah, perhaps the most difficult one is ones that I've already mentioned. They have folks that want coverage, that know the importance of coverage, like the 63 and 62-year-old from Twin Falls, Idaho, who want coverage, but prices got too high, $1,500 a month. So they're forced out of coverage. They actually went to the traditional style short-term plans, which aren't the better ones, and they're hopping from one company to another company until they turn 65. And in the meantime, that's hurting the overall risk pool. Or we have individuals that because of, they're, like I said, a spouse to a school teacher, they can't afford the dependent coverage on the school district's plan, and so they're forced to go without coverage. And if they're basically healthy, then they're choosing to take that risk on themselves. We believe that the appropriate use of short-term plans as in-between coverages is appropriate. It saves lives. It saves with early diagnosis and early treatment of conditions. And they have the opportunity then at the open enrollment then to move over to an ACA plan.
Well, I know that since 2013, premiums in the individual market have tripled. That's just since 2013 here in Missouri. So we're going to have to figure out some kind of ways to consider lowering premiums for the Affordable Care Act plans beyond just throwing more money at this problem. And my wife's car is having some issues, and so I'm going to head out now and yield back because I need to head over here to the dry cleaners and see if they can fix her car. I yield back.
I'm sorry, I didn't follow my own rules about unmuting. The chair now, let's see, recognizes Mr. Schrader of Oregon for your 5 minutes of questions.
Thank you, Madam Chair. Affordable Care Act's been an unqualified success for millions and millions of Americans. Having said that, there's still a few that unfortunately do not have access. Those in those states that decided not to do the Medicare expansion, which I find unbelievable. When I was budget chair in Oregon, it was a no-brainer. If the feds are going to, pay 95 or 90% of the bill, boy, I'd expand healthcare. It would save my state money in the long run. So hopefully, listening to testimony, states are gradually figuring out that they really need to do that. The other problem that was not anticipated in the Affordable Care Act is the problems with upper middle class individuals that do not qualify for subsidies. And Mr. Cameron's talked about that. Actually, you've all hinted at that. And I guess one of the cost containment options that you did think was reasonable, Ms. Cameron, was reinsurance or risk pools. Could you comment on that? As I mean, there's evidence that it can reduce premiums by almost 17%. Could you comment on that briefly?
Thank you, Congressman, for the question. In Idaho, we have a high-risk invisible reinsurance pool. So what happens, we actually take some of our premium tax dollars as well as some other funds that we were able to cobble together. Carriers, insurance carriers buy the reinsurance, so they have to determine whether they're going to cede the risk. And we help cover those most expensive treatment items with about 50% co-insurance, if you will, to the insurance companies. The consumer doesn't know that their condition is being reinsured, so they're protected. At the same time, it's helped lower costs over time. We haven't seen quite the level that you mentioned, although we're a small state with a small pool of money, and so we're only covering those high-risk items for which we can afford. The larger the pool, the more we could afford to cover. But I think that has promise. I think the bill would need some amending.
Very good, very good. Yeah, but I've heard both in Democrats and Republicans talk about risk pools, reinsurance programs. So there seems like an area of commonality. You also talked a little bit about the short-term plans. On one hand, some can be taken advantage. We've heard about the bad actors, but there are some good actors. It has a role. I actually like what you say about bridging insurance, longer-term insurance. And you commented that in Idaho, they had to meet at least the essential benefits that were in the Affordable Care Act. Is that correct?
Yes, that is correct. We actually went and drafted a bill, worked with the legislature, and allowed us to devise what we're calling the enhanced short-term plans. We'd prefer not to call them short-term plans, but that was the opportunity we could move forward.
Well, it would seem to me the goal of the Affordable Care Act was to make sure that you couldn't short-change to the comments that we've heard here today. Individuals who are not reading the fine print, and as long as you had the essential health care benefits in either a short-term plan or an association plan. I mean, that's if we had an association plans that were required to have essential benefits that were similar to the ACA, I think that would also be an area of commonality. Another point that my colleagues on the other side of the aisle bring up all the time are health savings accounts and flexible savings accounts. And is there a role for that, Mr. Cameron, in helping people that don't get the subsidies afford health care?
Absolutely. We're big fans of using the health savings account, particularly amongst those that are healthy. Those are some of the ideas that need to be discussed as we try and draw back the healthy of all ages back into the marketplace. People don't like buying insurance if they don't feel like they're going to need it or utilize it. And so then they end up with a situation where they're going bare and all of a sudden find out they have coverage or don't have coverage. So we think that there ought to be some options, some choices within the ACA that would openly allow health savings accounts so that those that are healthy can buy less expensive coverage and set more money aside in their health savings account.
Well, it seems to me there's a marriage here between making sure low-income folks get the cost-sharing subsidies they need, get the Medicaid coverage or subsidies in the Affordable Care Act, and then there's an opportunity at the higher end of the income spectrum to make sure they also can afford health care. That really is our goal here, making sure everyone has affordable health care. So I appreciate everyone's testimony. It's been very helpful, and I think this is an area we can get together and work on. And I yield back, Madam Chair.
The gentleman yields back. The chair recognizes the gentleman from Florida, Mr. Dunn, for your 5 minutes of questions.
So thank you very much, Madam Chair. Let me start by associating myself with Representative Schrader's remarks. I'm pleased to be discussing ideas to lower healthcare costs for the American people. As we all know, healthcare coverage does not always equal access to affordable quality healthcare. We're not better off if more people technically have coverage by insurance, but still face sky-high deductibles and exorbitant drug prices. I believe that price transparency throughout the healthcare system will empower patients to choose their care and ultimately lead to lower costs. Patients should be able to know how much a visit will cost before they show up, and they should know how that cost might vary at other hospitals, clinics, and offices. The physician-patient relationship also needs to be preserved. It is the pillar of the patient's trust in the healthcare system. Medical choices should be made by patients, doctors, and families, not bureaucrats. Physicians have the knowledge and the best interest of their patients at heart, and we should be wary of any actions by insurance plans to restrict choices and insert themselves into what should be doctor-patient decisions. As we think about transparency, preserving the doctor-patient relationship and lowering costs, we must focus on policy that drives value in the healthcare system. We can do this with policy incentives that encourage efficient, evidence-based, integrated care that considers the whole patient. We can and we must modernize our healthcare. We think we can improve healthcare outcomes while we lower healthcare costs. So, Ms. Jamison Carey, you're a proponent of healthcare price transparency to lower healthcare costs. What's the role of a physician when helping patients navigate the system, and how can physicians increase price transparency? Ms. Carey.
Thank you for the question, Congressman. Doctors want to show their prices. Doctors are on patients' sides. They're not on the sides of insurance companies necessarily. They want to know prices. They want to be able to tell their patients how much things cost, and sometimes they don't even know. Doctors come to me all the time saying, I just want to restore the doctor-patient relationship and get the hospital administrators, the government, and the insurance companies out of the exam room. But I spend the first 10 minutes of my visit with a patient answering questions to qualify for certain reimbursements or certain coverages, and it's a waste of time, and I need to get back to helping out my patient. Unfortunately, doctors are very nervous about posting their prices because there are two repercussions for them. They all want their prices out there, but they're afraid if they put their cash prices out there, that insurance plans will cancel them because their cash prices will look so much better than their contracted rates with insurers. I have also talked to doctors who've put their prices up, and the hospital tells them to take the prices down or they will lose their privileges because it's threatening to the hospital who charges 4 times more. So we need this to be open. We need to shine some sunshine on this situation. We need doctors to be free to post their prices and not to get the reprimands and to return the relationship and healthcare between the doctor and the patients, as you so eloquently pointed out.
So I agree. I mean, in my practice, we actually were forbidden from revealing prices publicly because that was equivalent, in the insurance company's view, of sharing, price fixing with other physicians across town. It was a crazy situation. The same is true, by the way, of other services. Radiology stands out in my mind. I was a patient this past year. And I want to talk to you, by the way, offline about this later, Ms. Carey. So do doctors in your association, Ms. Carey, have adequate access to price information across the system? It's funny, you alluded that many of them don't know the cost of the very services that they order and, for their patients. So is there something that we can do to help them know that?
Well, I think if you made it easier for everyone to have their prices transparent, they would really appreciate that because they referred a patient to an MRI and they don't always know how much that's going to cost them. And they would like to be good stewards of their patients' finances, and they don't have enough access to prices themselves. They almost have the same access the rest of us have. So they're operating in the dark. So we get more sunshine and more transparency. They're going to be able to steer their patients to the best value providers. Also, if they remain independent, they're not required to forward all their patients into the health system where costs are the highest. So employed physicians must refer into.
We're running out of time, but I want to talk to you later, your association later, and say I can't agree with you more. We were literally forced to turn patients back into a system that outrageously overcharges, and I have great examples of that. Thank you, Madam Chair. I yield back.
Thank you.
The gentleman yields back. Pleasure to recognize the gentleman from California, Dr. Ruiz, for your 5 minutes of questions.
Thank you, Madam Chair. Today we celebrate 11 years since the Affordable Care Act became the law of the land. This historic life-saving piece of legislation has helped millions of Americans access health care. And as this past year has made clearer than ever, having an affordable option that is not tied to employment is critical to the millions of families that rely on the marketplace or Medicaid for their health care. Of course, there is still more that needs to be done, which is why we are having this hearing today, and why it was so important that the American Rescue Plan was just signed into law to expand coverage and reduce the cost of healthcare for millions of Americans. As I have been on the ground administering vaccines to underserved communities in my district, I can say unequivocally that now, during this public health emergency, is precisely the time to expand healthcare. Access to healthcare is a human right, not a privilege for just a select segment of the population. Whether or not someone has access to affordable healthcare should not depend on their zip code or how much money they make or how healthy they are, which is why we must keep working to reduce gross health disparities, achieve health equity, and create an America where every person has access to quality, affordable health care. And on the topic of health equity, today I would like to focus on an area of health equity that doesn't get as much attention as it should, the Indian Health Service. Today we are considering my bill, HR 1888, the Increasing Access to Indian Health Service Act, which extends 100% federal Medicaid medical assistance percentage, the FMAP, to urban Indian organizations and allows tribal health programs to receive reimbursements for services provided outside of the four walls of their clinic. IHS provides healthcare to 2.2 million American Indian and Alaska Natives every year. Across the United States, 41 urban Indian health programs provided medical services to over 65,000 people per year. Even though they are a vital part of the Indian Health Service provider network, they only receive about 1% of the annual IHS budget. Furthermore, urban Indian health programs are the only IHS facilities that don't receive 100% FMAP for Medicaid services. Under the American Rescue Plan, I successfully advocated that for the next 2 years, urban Indian health programs will receive 100% FMAP, but this is merely a temporary policy. We need a permanent fix. Ms. Mann, what is the current FMAP for the urban Indian health programs?
The services that are provided through the Medicaid program would be at the state's regular Medicaid match, Congressman. So in California, that would be 50%. And so a very significant difference from what the American Recovery Plan has provided and what your bill would provide on a more permanent basis. And you're absolutely right. It's the one portion of that delivery system which is left out of the 100% match. Really important.
And is there any policy basis for this disparity in how the federal government funds services received through different Indian health providers?
I believe it is like the Medicaid expansion, it's sort of an accident of history, right? In terms of who was excluded and who was not excluded. So I would defer to you to have a better sense of that specific history. But there's no sound policy basis that I know of, Congressman.
Thank you. Thank you. A 100% FMAP for UIOs means the federal government would cover a greater portion of Medicaid care. Is it fair to assume that this could help incentivize states to increase pay rates to these financially strained providers?
I think it can. I think it can help them increase pay for staff. It can help them provide better navigation help. It can help them address things like social determinants. It can really provide a more robust platform of providing care and assistance to people.
It is critical that we pass my legislation to ensure this long overdue policy is implemented permanently. Finally, Ms. Mann, I'd like to ask you about the other provisions of HR 1888 that would permanently allow IHS clinics to receive Medicaid reimbursement for services provided outside of their clinic. The administration recently extended the grace period that allows for this type of reimbursement through the end of fiscal year 2021. My understanding is that there is nothing in statutes or regulations that guarantees that this ability to bill Medicaid for these services will extend beyond that date. Ms. Mann, would it be beneficial to ensure that tribal healthcare providers can maintain this reimbursement for care outside of the four walls of their clinics beyond 2021?
Absolutely. And there have been steps taken under the Obama administration were taken to be able to extend that 100% FMAP for contracted providers, but it has not been as even-handedly provided for as your legislation would do. And I think there's been a lot of temporary flexibilities that have been granted during the pandemic that states and the federal government and healthcare providers need to look carefully at and determine which ones ought to be made permanent.
Thank you. I yield back.
The gentleman's time has expired. The chair is pleased to recognize the gentleman from Utah, Mr. Curtis, for your 5 minutes of questions.
Thank you, Madam Chair. I am so grateful for all of our witnesses today. I'm finding myself wishing I had an hour with each one of them. Thank you for your thoughtful testimonies. A quick thought, not a question, Ms. Jamison Carey. I actually had 4 surgeries last year, and I can speak firsthand to the confusion of pricing. And one of the points that I don't think was made, but I'd like to throw in here is this confusion and the multiple bills that come after surgery make it very, very difficult for the average consumer to get insurance reimbursement. And I'd just like to kind of throw that in to validate your point in addition to what you've said. And Mr. Cameron, we have a couple of connections. We share a border. I'm from Utah. I noticed in your bio, you're a 3rd-generation insurance agent. My father was an independent insurance agent, and his father was an independent insurance agent, and I broke that 3rd generation link. And in hindsight, maybe I should have got into insurance. But I remember my father taught me a couple of lessons when I was very young about insurance that I feel like we have forgotten in today's world. The first was that you only buy insurance for things that you can't afford to pay for. And I feel like in today's world, we want insurance to cover $1, and we could reduce the cost of insurance, I think, if we could remember that. The second thing he taught me was to never get a traffic ticket because it makes your insurance go up. And it's a very simple example, but I think we also forget sometimes what we do that causes the cost of insurance to go up. Now, a question for you, Mr. Cameron. In the last Congress, I had a bill. It was called the American Health Share Plans Act. And in essence, what it did is it would permit member companies, Costco's maybe a good example that would come to mind for everybody, or similar companies like that with memberships, to sponsor healthcare plans, particularly across straight lines. For more, in Costco's case, they have 84,000 members. Have you heard of that plan? And do you see how plans like that, large and small, might be able to help us reduce the cost of health insurance?
Yeah, certainly. Thank you for the question, and thank you for being a good neighbor. First, we have worked very carefully with association plans. We've also worked with our legislature on a bill for selling across state lines. It can be done. The biggest fear about selling across state lines is where does the consumer go when they've bought a plan that's not licensed in Idaho? Where do they go? And so we were able to address that with collaboration of other states that are surrounding us, with Utah, Oregon, Washington, Nevada, Wyoming, etc. And so we've been able to address that. We have been working also with association health plans. The biggest dilemma there is in many cases, some of the associations want to just carve out special niches and insure those. And we've pushed back on that and said, look, you've got to take everybody who's a member of that association. If you're a chamber, you've got to take everybody who's a chamber.
And you'll excuse me for jumping in, but we've got such little limited time. I would like to just reiterate something that you said in your opening remarks about the states being laboratories. And I think you've brought many good examples today. I wish we could bring all 50 state commissioners to the hearing to learn individually what they've learned about all their different ways they've approached things. Quickly, Ms. Mann, we've heard a lot of emphasis today on why not all the states are jumping into Medicaid expansion. And I have a theory on that, and that is that we want this one size fits all from Washington, D.C. without letting them have any flexibility. Bipartisan healthcare solutions in the Medicaid program include 12-month continuous coverage in addition to promoting greater fiscal responsibility with the waiver program. Utah was previously approved for waiver that included work requirements. That's important in our state. But the Biden administration recently notified the state that this waiver didn't promote the objectives of the Medicaid program. Do you believe we could get more participation from states and have better policy if we didn't have this one-size-fits-all Medicaid approach?
Congressman, it's a really important question. And I would say that first, I'll get to the work requirements issue in a second, but first, there's enormous amount of flexibility in the Medicaid program. And, you know, there's the common phrase, which I think is accurate, which is if you've seen one state's Medicaid program, you've seen one state's Medicaid program. States decide on their delivery systems and their payment rates.
Miss Mann, we're going to run out of time. I would love to let you go because you have so many important things to say. Let me say in the last few seconds I've got just a real plea for the individual needs of states, realizing that we don't have all the answers at the federal level. I wish we had more time. I'm sorry I'm out of time.
I couldn't agree more.
Thank you.
The gentleman
Chair,
yields
you know.
back. Thank you, Mr. Curtis. Good exchange. I learn so much in hearings. I love hearings. They are long, but they're highly instructive. It's a pleasure to recognize the gentleman from Maryland, Mr. Sarbanes, for his 5 minutes of questions.
Thanks very much, Madam Chair. I'm very honored to have Ms. Hadger on this panel as one of my constituents today, and I want to thank her for her very important perspective. Ms. Hadger, thank you for sharing your family's story. I wondered if you could describe a little bit more the challenges caused by the COVID-19 pandemic in terms of the impact on your family and how you were able to access the ACA marketplaces for coverage in view of that, and just generally share your perspective on why that kind of coverage opportunity is so critical.
Thank you so much for your question. It's a pleasure to be here as well. First, I just want to recognize that so many people, particularly communities of color, who we know have been very hard hit by this pandemic, have had it more difficult than I have. I'm grateful for my ability to work from home, and I'm grateful for my resources like computers that I've been able to take advantage of. But having said that, the COVID pandemic has been very hard on my family, as it's been for many others. I mean, for my daughter, who's a senior in high school, she's missed pretty much every milestone. For my son, online learning has been really hard. He's got cognitive disabilities, and remote therapy and remote classes, you know, I'm very worried about the regression that this may have caused him. It's also been really hard to juggle supporting Simon in those ways and, you know, try to work full time in this current economic environment. Losing Simon's DSP, losing those kinds of supports, that's been a real blow. We were really focused on working towards his independence, and not being able to have those resources has made it even more challenging in an already challenging time. Being able to access the ACA has been one of the bright spots. It's allowed us to have the security of knowing that we have health coverage, especially when, you know, we're in a global pandemic and it's pretty scary out there when it comes to one's ability to maintain one's health. Having the ability to choose what program we went with, having the ability to have the Medicaid support for Simon has been enormously beneficial.
Thank you very much. Appreciate that. You know, one of the things that the American Rescue Plan did was it built, as we know, on the Affordable Care Act in significant ways, potentially transformative ways, making it possible for more Americans to access in an affordable way healthcare coverage at a time when they were struggling financially. It expands the ACA's tax subsidies, including for the first time to Americans above 400% of the federal poverty line. And we know that this has been a real issue for families across the country, so the ARP was a meaningful response to that challenge. Ms. Keith, can you talk briefly about how many individuals are expected to see their monthly premiums decrease as a result of the American Rescue Plan, sort of what we built onto the ACA and improved it, and how many uninsured individuals will qualify for these expanded subsidies?
Thank you for that question. So the current 9 million in subsidized enrollees are going to see their premiums go down. They can return to healthcare.gov or their state-based marketplaces in most states beginning on April 1st and start to see savings on average about $50 per month per person. So big savings, money back in people's pockets. That's in addition to the 14.9 million uninsured people who will be eligible for these subsidies, including the 3.6 million uninsured families who are above that 400%, the poverty line threshold that you mentioned, who have never been eligible before. And I think this is going to really close the gap for some of the people that have enrolled in the short-term plans and the healthcare sharing ministries and have really been cut off from access. I think it's going to be transformative for these families.
Appreciate that very much. You know, for a long time, we've talked about how we could build on the foundation of the ACA, strengthen it, expand it, lift it up higher. For years, we had to be in a kind of defensive posture against the repeal efforts, and that made it hard for us to do that. The American Rescue Plan has shown that there really is a path forward to expand coverage and to view the ACA as that bedrock. And I think we can learn from that, Madam Chair, and continue to offer great ideas to strengthen and improve coverage for all Americans. And I yield back.
The gentleman yields back. It's a pleasure to recognize our colleague from Georgia, the ever moving around in his car every time we have a hearing. Mr. Carter, how are you?
I'm good, and thank you,
Good.
Madam Chair. I appreciate it. I'm trying to figure out how to do the background so you won't know I'm in the car, but nevertheless, I want to truly thank you for this hearing and thank the panelists. This is a great hearing, a much needed hearing, certainly something that we in the state of Georgia, this is important because I will tell you that we've been working for the last 2 years to try to figure out why almost 1 million Georgians that are uninsured and are eligible for subsidies under Obamacare have not enrolled in the exchange. And about a little bit over 150,000 of these that are eligible for the bronze plans would have 0 or single-digit premiums per month. And we found that there are really 2 issues. First of all, we need to get to the people where they buy their insurance. And secondly, the insurance is still far too costly. On the first issue, and that is about getting the people to the insurance. Georgia's proposed not using healthcare.gov and instead using a network of private web browsers, such as our web brokers, I should say, such as Health Sherpa or Get Insured and other health insurance carriers to find people where they are. And what I wanted to ask you, Mr. Cameron, is have you found that brokers, in your experience, are more successful enrolling people than federally trained navigators?
Absolutely, Congressman. I will tell you that Idaho has its own state-based exchange, and we did it for some of the same reasons you've talked about. We're the only Republican state that has a state-based exchange. We'd welcome others to join us because we think it can be less expensive and be able to reach more people.
So not using healthcare.gov has not hindered enrollment in Idaho?
Not at all. That's not our issues. Our issues are affordability and those folks who don't believe they need the coverage.
Okay, so that's the first problem that we had. The second problem that we've had on the second issue, Georgia's 1332 waiver is also planning a reinsurance model so that we can lower premiums up to 25% in some rural areas where there's less competition. And listen, there are 2 Georgias. There's Atlanta and there's everywhere else. And in South Georgia, it is a problem, a big problem. We don't have as much competition as we should. But if we were to do this, Mr. Cameron, can you talk about how reinsurance in Idaho and how it's helped to lower premiums?
You bet. And first of all, we didn't use the 1332 waiver. We attempted to, frankly, found that the 1332 waiver process was too cumbersome and too difficult for what we were going to gain from it. So we just adopted our own program. We look prospectively. We have 1/4 of our premium tax looking prospectively is deposited into our account. We set up the reinsurance process with a board that I appoint that is made up of both consumer advocates as well as insurance carriers. And the insurance carriers have to pay a premium in order to buy the reinsurance. Plus, they can be assessed if we ever get upside down. We're not. We're operating in the black with several $1 million carrying over from year to year. And it does help reduce rates. And we hope it will reduce rates more significantly down the road as our pot continues to grow.
Well, we may reach out to you to find out exactly how you were able to do it. We're trying to do the 1332 waiver in the state of Georgia, and I hope that this administration doesn't think that it knows better than what we know in Georgia, what we need. And I hope that the flexibility that the 1332 waiver offers is absolutely crucial to getting more Georgians access to quality, affordable health insurance. So we'll be monitoring this, and Mr. Cameron, we may be in touch with you to find out how you could help. But my message is simple, and that is we don't need to be litigating this 1332 waiver. This is something that's extremely important to the state of Georgia, and I hope that we'll be successful in this. And with that, Madam Chair, I'll yield you back 30 more seconds.
We thank the gentleman who yields back, and drive safely. I think someone else is driving, right?
Oh, yeah.
Hopefully. It's a pleasure to recognize the gentleman from California, Mr. Cardenas, for your 5 minutes of questions. Great to see you.
Great to see you, Madam Chairwoman, all of my colleagues, and thank you so much to all of the witnesses who are giving us some insight and expertise about what's going on out there in America when it comes to healthcare. And also, I'd like to thank the Ranking Member Guthrie as well for having this hearing. The Affordable Care Act, the ACA, significantly reduced racial and ethnic disparities in health coverage for children, including by reducing the coverage gap between Latino children and all up to 3 points in 2016. Nevertheless, according to recent research by Unidos US, the Georgetown Center for Children and Families, the gap between coverage rates for Latino children and all children widened in 2018 for the first time in a decade, threatening to undo the progress of the ACA and placing Latino children in a more vulnerable situation in the years prior to the pandemic. Ms. Keith, what can Congress do not only to reverse the trend and restore the gains of the ACA for Latino children, but fully close racial and ethnic coverage gaps for all children?
Thank you for that question. And I would also welcome Ms. Mann's comments on this as well, since she focuses on this issue. I think there's many things that can be done, including extending coverage, as you all just did under the American Rescue Plan, to parents, and making sure that parents have access to affordable coverage, because that translates to children's coverage gains. There have already been steps to roll back the public charge rule, which was disincentivizing enrollment. And again, I think having Navigators, outreach, and enrollment, making folks aware that these options are available is going to be critically important, including in Spanish language and with trusted partners out in the community doing this very important work. Much to be done, but many gains that could be made.
Thank you. And Ms. Mann, if you can answer that with the additional question that I have for you. Thank you so much, Katie. The ACA helped provide coverage to at least 4 million Latino adults and 600,000 Latino children once the ACA became law. But many of the law's benefits remain inaccessible to millions due to their immigration status, including those with deferred action for childhood arrivals, otherwise known as DACA. Latinos continue to have one of the highest uninsured rates in the country at nearly 19% in last checked in 2019. And non-citizen Latinos have higher uninsured rates than all other non-citizen groups, regardless of income or work status. Ms. Mann, as Congress considers how to build upon the ACA and expand coverage, what can it do to better integrate individuals otherwise left out due to their immigration status?
Thank you, and it's a really important question. We, as Katie had noted, the public charge rule certainly chilled people's ability to get care and to sign up for coverage, even when they were eligible. So that rule has now been repealed, rescinded, but it will take a lot more than rescission to be able to really restore trust in among families, that they can go and apply for the kind of coverage that they are in fact eligible for. Many mixed households, immigration households with citizen children, were refraining from looking for coverage and seeking care, and that's very unfortunate on all levels. So we need to really be aggressive now about getting the word out and making sure people do feel comfortable when they're eligible. Then there's the issue of some people just simply aren't eligible. There's still a 5-year bar for many lawfully present individuals to be able to access Medicaid coverage and CHIP coverage, and that can be addressed. And there are certain groups of people who are lawfully in the United States, including the DACA people who don't qualify and could be brought into coverage programs through federal changes.
Thank you, Ms. Mann. I have a question for you, Laura, Ms. Hatcher. Are you aware, Ms. Hatcher, that Congress tried to end the ACA more than once?
Thank you for your question. Yes, I am aware of that.
How did you and your family feel when you witnessed that over and over and over? Did it seem like no big deal, or was it something that actually you felt afraid if the ACA were to end?
When Congress initially began the attempt to repeal the ACA, I felt frightened and powerless. And then when I watched adults with disabilities lining the hall.
We have 10 seconds, Laura. Let me ask this one question. Did it feel like life and death for your family, perhaps? If the ACA were repealed?
It is life and death for my family.
It is life and death. Ladies and gentlemen, millions of families are in the same situation. Let's make the ACA better and stronger for every family in America. I yield back.
The gentleman yields back. Pleasure to recognize Dr. Joyce of Pennsylvania for your 5 minutes of questions.
Thank you for yielding, and thank you, Madam Chair Eshoo and Ranking Member Guthrie, for holding this hearing. And thanks to all the panel for appearing with us here today. Mr. Cameron, you mentioned in your testimony that the 1332 waiver process was too burdensome and difficult, and you were able to implement a reinsurance program without it. Congress has debated increasing flexibility in 1332, and the Trump administration's guidance provided as much flexibility as it could within the law. Do you think, Mr. Cameron, that Congress should look to build on the Trump guidance and increase the aforementioned flexibility?
Well, thank you for that question, Congressman, and that's a tough one. I think that Congress should look even further, and I'm not going to suggest we build on anybody's foundation. I think it should look further to allow states to be the laboratories of innovation, of laboratories of creativity. Some of the provisions in law didn't even allow. We were trying to get to 1332 under the Trump administration, and frankly couldn't. And you would have thought we would have been able to, but couldn't because of some of the barriers and strict interpretation of the law. Things like the demand that it be cost neutral, and yet they would define what we could measure in order to make it cost neutral. We could show where we were reducing costs for all of for the ACA patients or ACA members as well as others, but it still wasn't allowed. So it's sort of a sore spot in our journey.
Mr. Cameron, let's continue along the line on state innovation. HR 1796 before us today provides grants for state innovation. Yet the Biden administration has suggested it may repeal the Trump 1332 guidance. Do you recommend that Congress increase the 1332 flexibility to get the best use of the proposed state innovation dollars should this proposal move through committee?
Absolutely. To throw additional grant money at it doesn't help unless you're going to expand that ability for states to do things. And I would strongly encourage to allow, every state's different. Although we have commonalities, every state has their unique challenges, and we should allow states to innovate and hopefully find solutions to lowering costs.
You suggest in your testimony going from a 3-to-1 age ratio to 5-to-1. Is this something currently permitted under 1332 today, or is that a flexibility that we should be exploring and providing to states?
Absolutely. It is a flexibility that you should be employing. You should at least have the GAO or some private enterprise study it, but we think that flexibility should be there to states. We did our own actuarial analysis using a private firm, and it would, by expanding from 1 to 5, it would lower costs for everyone, not just the young, but for everyone. So even the seniors would be able to take advantage if you went to a 1 to 5 instead of a 1 to 3. But it's not permitted under the current statute, at least according to CMS.
I'm certainly encouraged by lowering the cost to seniors, to individuals of all ages, and to state innovation, the point that you have made repeatedly, and that is so important for us to understand that each state is individual. So if this committee chooses to move forward with HR 1796, what are your specific recommendations in terms of how those funds should be structured and how those funds should be used?
Well, thank you. And I don't know that I'll give you as specific of an answer as I would like to. First, I would use those funds to allow for that innovation, that creativity, to allow for systems like what Idaho's done, where we're trying to attract the young and the healthy. If you don't figure out how to attract the young and the healthy back into the ACA, the ACA will continue to spiral out of control, and even families like Miss Hatcher will be eventually forced out of coverage unless they're on Medicaid. To me, I think we've got to figure out ways to attract the healthy of all ages and the young back into the marketplace. Doing away with the Congress and the American Recovery Act address those above 400% of poverty. As we look at it, that you could go forward with addressing those in the family glitch.
I thank you for your comments. I see my time has expired, and thank you, Madam Chair Eshoo, and I yield.
Good questions, Mr. Joyce. I'm going to have to step out for a short period of time, and our colleague, Mr. Sarbanes, is going to step into the chair. And I believe, Mr. Sarbanes, well, first of all, thank you. And I believe the next member for you to recognize is the gentlewoman from Michigan, Ms. Dingle. So thank you. I shall return.
Thank you, Chairman Eshoo and Ranking Member Guthrie, for convening today's hearing on discussing a number of reforms and doing it to strengthen Medicaid and the Affordable Care Act on the 11th anniversary. I can't help but think of John today and all that he did for healthcare for many years. And he would say to Republicans and Democrats gathered, we need to work together. But I'm also reminded of his father, who was one of the authors of Social Security. And some of the things I hear today were said 80 years ago. And it's such a part of our fabric now that I hope we can all work together so that every American's got access to health care. I appreciate the inclusion of my legislation to make permanent the money follows the person rebalancing demonstration act. Since it was authorized, the money follows the person rebalancing demonstration has helped many Americans transition from institutional care to their homes and the community. Money follows the person has led to positive health outcomes for the beneficiaries. It's improved the quality of life, and it's generated savings for Medicaid and Medicare. Despite these benefits, someone not being institutionalized, being in a home care setting, and not costing as much money because they are at home and not an institutional setting, it doesn't have permanent authorization of funding. Instead, Congress has passed 5 short-term extensions to ensure program continuity. This uncertainty in funding, as well as lapses in funding, has caused some states to walk away from the program and has led to declines in efforts to transition individuals from the institutional setting to the community over the years. Ms. Mann, Evidence has clearly demonstrated that funding uncertainty has had a damaging effect on money follows the person programs. Can you specifically describe the short and long-term impact this has had on beneficiaries?
Absolutely, and I applaud the introduction of that legislation, Congresswoman. It's as you say, it is a strongly supported, bipartisan supported program, both in Congress and in states across the country. I was at CMS at one point when money follows the person was expiring, and it really caused a great deal of havoc and concern among both the individuals who were getting assistance from that, among the states that had been funding programs to do, as you described, to help people transition from nursing homes into the community, to help people stay in the community and avoid institutional care when they needed long-term services and supports. It's just an incredibly important bridge that provides a lot of flexibility in the way that people have been talking about. And when there's not certainty about the long-term funding for a program like that, then there's a lot of worry in the community, and also it impairs states' abilities and communities' abilities to plan programs and really try and invest to make sure that the program is as effective as possible. So having that stability after how long it's been in place will be a value added for everybody.
So let me ask you another question that I think is really important. When MFP participants transition from receiving care in nursing homes to community-based settings, do Medicaid programs experience cost savings as a result?
On a per person basis, it is overall much less expensive to care for people in the home. It's not cheap, but it is far less expensive than in the nursing home. And it is people's choice as well to be back and stay in their homes or back in their homes and in their communities.
I got 1 minute left. Do you think that a consistent, reliable funding stream for money follows the person would help the revitalized programs that have struggled over the past years and encourage states that wound down their programs to reinstate them?
Absolutely. Absolutely. States are loath to jump in and set up new structures and fund services through it if they're not certain that the money will continue to be available.
And in 30 seconds, how would making this permanent part of the Medicaid program benefit institutionalized beneficiaries seeking transition to the community?
Well, often the idea of you're in a nursing home and the idea of leaving that institution to go in the community is just very difficult for people to think about how to do that. So help finding affordable housing, help paying for that transition, providing ramps and retrofitting apartments or housing to be able to make it doable for people, to be able to then also arrange for the care that they might need at home. It's all those components that can be very scary step for a lot of people, but one that they're eager to do if they have the support.
Thank you. Thank you, Mr. Chairman. I yield back.
Thank you, Congresswoman. I believe now Congressman Crenshaw, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you, everybody, for being here on such an important topic. Look, I'll start philosophical and then get into my passion on direct primary care, which I'm new to this committee, but you'll hear a lot out of me on direct primary care over this session. But starting at the 30,000-foot level, look, I don't want to keep funding things that aren't proven to work well. We should be creative and flexible about how we deliver care. If we agree on the fact, and I think we actually do, that Americans need access to good health care. The question is how we do it. And when you're looking at a program like Medicaid that we continue to fund endlessly and unsustainably, and yet it does not have a correlation with improved outcomes. Study after study shows this. Now, again, nobody's saying that Medicaid causes bad outcomes, but if there's no correlation between Medicaid and good outcomes, then we should at least have some questions in mind and be looking for more innovative solutions besides just increasing it endlessly. Yesterday, we heard about how important primary care is. It is the gateway to healthcare. This is why direct primary care is such an important focus of mine, and I think that we could have some bipartisan agreement on it. I've heard in this committee hearing that there's already bipartisan agreement on the success of reinsurance programs as a way to solve the tail end of the problem, where costs get so overwhelming that insurance companies can't cover them without raising premiums to extraordinary levels. And so an invisible reinsurance program works well for that. But we have to focus on the beginning of this too. And in Texas, we've had really interesting success with self-funded programs where a company will contract with a direct primary care physician. This does a few things. It immediately has an outcome of a direct relationship between the doctor and the patient with no extra costs or co-pays. It also reduces their premiums on the back end as they renegotiate with their insurance companies. It's benefits all around. So how do we expand this model is going to be a question of mine. I have a bill that does that. My first question to Ms. Carey: you lead an association of doctors who want to remain independent, and are doctors you work with participating in the direct primary care model?
Yes, thank you for the question. It's such an important topic. In fact, last year we surveyed our members and I asked them how many of them had a direct primary care practice or a direct, I like to call it direct care, because I do think there are specialists, that pediatricians and obstetricians and gastroenterologists even, that would like to practice direct care. And I asked how many were already doing this. It turned out 30% of my members already were in a direct care model or had a hybrid, and 30% wanted to move in that direction. Another 30% felt that they just simply couldn't. They're radiation oncologists and feel very wedded to the insurance plans. But for those who can move in that direction, they are experiencing far more freedom, far less regulation, and their patients and employer populations are enjoying greatly reduced prices. It's an excellent way to go.
It is, and correct me if I'm wrong, on average, I'm told it's about $75 a month. So we're talking a gym membership, basically. Now, I realize that it's not insurance, but this is a long list of services that you get a quarterback. You get a quarterback for your health care. And nobody has that in America right now. That's, well, not nobody, but a lot of people don't. And that's really frustrating, I think.
I think that if employers could put that money, that $85, $75 per employee, or $125 for a family, and allow for those members, those employees to get primary care, their labs, their well care, their radiology, all of that included. The rest of it can start to take care of itself with the self-insured employers. They can start covering some of those bulk costs, and it would save. The studies I have seen, the employees are extremely happy with the quality of care, the access, and the employers are saving 50 to 70%.
No, thank you. And the next question people have, of course, is, well, not everybody can even afford $75 a month. So my bill would allow for 1115 waivers to provide direct primary care to low-income patients and through more flexibility through Medicaid. So, Mr. Cameron, do you think that that's something we're looking at in Texas? It obviously takes a waiver at the federal level and then cooperation at the state level. Would something like that work in Idaho as well for increased flexibility?
Absolutely. We've attempted to promote direct primary care as well. One of the problems is the ACA has primary care loaded into the price. And so if you really, in some ways, ended up paying twice for that service. So we would welcome 1115 waivers or whatever waiver is necessary to allow that experimentation at any state.
Thank you, and I yield back.
Thank you very much. I believe Congresswoman Custer is next. You're recognized for 5 minutes.
Thank you very much, Mr. Chairman, and thank you again to the chair for having this important hearing. We need to repeat the fact the ACA has resulted in more than 20 million Americans gaining health coverage, and its consumer protections have ensured that millions will no longer face discrimination for pre-existing conditions. There are over 52 million Americans and over 200,000 right here in the Granite State who live with pre-existing conditions every single day and could have been denied access to health care prior to the ACA. The ACA required insurance companies to comply with comprehensive consumer protections, but we all know that junk plans are exempt from them. A committee investigation found that these short-term, limited duration plans offer bare bones coverage, and subject consumers to an invasive review process on the back end in order to avoid paying for medical claims. These junk plans require consumers to provide up to 5 years of medical and prescription drug history. Ms. Keith, I'll start with you. I understand that it's common for junk plans to refuse to pay for medical claims if they determine that it was due to a pre-existing condition or resulted from a pre-existing condition. Is that correct?
That is, yes.
And can you describe why Americans with these junk plans are left with thousands of dollars in unpaid medical bills despite having insurance and paying premiums?
Yes, thank you for that question. So the reason that patients get left with bills is because the coverage that they're in simply doesn't cover much. There's huge benefit gaps, as we've heard, not covering prescription drugs, not covering mental health care, not covering substance use disorder services that we've heard many members talk about being very important, very high out-of-pocket costs, and then the practice of rescissions, which we've discussed.
And another policy that surprised me, I understand that junk plans rescind the underlying policy, a practice that's banned by the ACA. Is that also correct?
It's correct that the ACA banned rescissions except in the most narrow of circumstances like fraud.
Thank you. And yes, these junk plans rescind the coverage from patients if they decide that the consumer should have disclosed certain risk factors on their application. The committee investigation found that a patient was billed $190,000 for a treatment related to a heart condition, and the company rescinded the coverage because the patient failed to disclose he was previously diagnosed with diabetes. Junk plans also rescind coverage of cancer patients and deny claims related to cancer treatment. Simply put, these plans are a backdoor way to deny coverage for Americans with pre-existing conditions and bog them down with red tape paper trail requirements. They put vulnerable Americans at risk and leave families with massive supplies bills. Ms. Castor's bill to subject these junk plans to the ACA's comprehensive consumer protections is important, and I'm very pleased today to be reintroducing my legislation entitled Protecting Americans with Pre-Existing Conditions to ensure the consumer protections from the ACA cannot be undermined. And with that, Mr. Chairman, I will yield back, or I could yield my time to anyone else that needs it.
Seeing none, we'll take your time back. And I believe now, Congresswoman Kelly, you're recognized for 5 minutes.
Thank you, Mr. Chair. Professor Keith, in your testimony, you mentioned that Black and Hispanic individuals have seen the highest gains under the ACA, which has afforded them less costs related to prohibitions to care and greater access to primary care. Can you tell us a bit about how the American Rescue Plan will help address inequities not only in the Medicaid population, but as well as the population who don't qualify for Medicaid, but are still low income and subject to inequities in healthcare coverage?
Yes, thank you for that very important question. So Black and Latino communities in particular have seen the largest coverage gains under the Affordable Care Act, and the American Rescue Plan is going to even further those coverage gains and the progress that needs to be made. So hundreds of thousands of people of color will be newly eligible for subsidies because their income was too high and will be able to enroll and find an affordable coverage option now. You mentioned this, but the data does show that when folks have access to high quality coverage, it helps get them access to care. There's more work to be done and certainly around disparities, but I think this is a very strong start and continues to build on the progress that's already been made.
Thank you. Ms. Mann, in your testimony, you discuss how Medicaid expansion was significantly associated with a reduction in maternal deaths, with positive effects concentrated among non-Hispanic Black women. As you may know, I am an ardent advocate for maternal health. In fact, part of my legislation, the Helping Moms Act, was included in the American Rescue Plan, which expanded Medicaid coverage to postpartum mothers from 60 days to 1 year after birth. Can you possibly talk about how the expansion of Medicaid and making CHIP permanent in conjunction with the extended coverage of postpartum mothers work together to not only reduce maternal mortality in the U.S., but also have a positive impact on Black mothers who die at a higher rate than their peers?
It would be a pleasure to respond to that, and thank you for your advocacy on this incredibly important issue. As I'm sure you know, the 60-day postpartum coverage period that has been part of the Medicaid program for a couple of decades was not based on science. It was a number that was picked and it provided some postpartum coverage for people. But increasingly, as we've seen that the mortality rates and the morbidity rates increase, particularly among women of color and Black women in particular, more look at investigation has gone on and more consideration about how those problems arise, and many arise in the postpartum period. So we've seen just a strong agreement across health professionals, around women's organizations and others, that the extension to 12 months postpartum is consistent with the science and will be incredibly important as a way to reduce those disparities. The permanent authorization of CHIP will also contribute to reducing those disparities and help around prenatal care and postpartum coverage as well. As you know, CHIP has an option to cover pregnant women. It's mostly for children, but it also has a pregnant women option. And so extending that option for CHIP and then making CHIP a permanent program will ensure that the benefits of those policies will reach a lot more women.
If I can just go back again to maternal mortality, there's concern that making optional the provision in the American Rescue Plan that extends the postpartum coverage means a number of states that have not chosen to expand Medicaid will also choose not to extend Medicaid coverage to postpartum moms, such as Texas, Alabama, and Mississippi. Do you think any of the bills discussed here today, especially the increased FMAP under HR 340, the Incentivizing Medicaid Expansion Act, would entice states that we suspect would not extend the coverage to postpartum moms to extend it? Very, very concerned about that.
Absolutely. It's there is discussion in some non-expansion states on the postpartum coverage. There was some proposal to do that in South Carolina, but by and large, it is a proposal that is considered in the context of a broader Medicaid program. And I think I don't know if you were here when we talked earlier in the hearing about just last night, Wyoming passed a bill in the House to expand Medicaid thanks to the incentives in the American Recovery Act. Alabama is considering it, a state obviously with a very significant disparities in health driven by race and ethnicity. So I think what you've done is in combination is really opened eyes and provided some really very significant investments for states to reconsider whether they do the expansion and hopefully also extend the postpartum coverage period.
Thank you, and I yield back time I don't have. Thank you.
Thank you, Congresswoman. Congresswoman Barragan, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. Today is a great day to celebrate the ACA and what the Affordable Care Act has been able to do for expanding access to health care to many underserved, to many low-income families and communities, and the impact that it's had has been enormous. Today, we also discuss bills that build on the Affordable Care Act's historic coverage gains. And I want to start with the CHIP program. And Ms. Mann, this is going to be for you. The Children's Health Insurance Program is one of our nation's most important healthcare programs by providing health coverage to 9.6 million low-income children, including nearly 1.3 million children in California. Despite being so vital, CHIP is currently the only federal health insurance program that requires its funding to be reauthorized periodically. This dangerous precedent leaves the program vulnerable to potential lapses in funding. This occurred in 2017 when CHIP temporarily expired for over 4 months, putting states at risk of running out of money for the program and threatening the coverage of children who rely on CHIP to get the care they require. This should never happen again. My bill, the Children's Health Insurance Program Permanency Act, will ensure that funding for this program will no longer be held hostage during partisan budget battles. Our goal should be to make sure every child in this country has access to the medical care she or he needs when they need it. I want to thank my committee colleagues, Congressman Cardenas, Congressman Rush, and Congresswoman Schreier for co-sponsoring this important legislation. Ms. Mann, can you please discuss CHIP's importance for children and how periodic reauthorization battles threaten the program?
Absolutely. Thank you for the question, Congresswoman. CHIP has been a really valuable impetus for reform for coverage for children. I was around and working on children's coverage issues in 1997 when the Congress passed CHIP. And no one knew exactly how many children would be covered and how many states would pick it up. Every state picked it up by 2000, so just in 3 short years. And it's been such a popular program, helping to allow states to expand their Medicaid programs to cover more children in Medicaid, as well as to set up separate children's health insurance programs. It's really been a lifeline. I've also been around long enough to see what's happened when the reauthorizations didn't occur in timely ways. We saw the first time that happened, we saw some states stop taking new applications. They didn't know if the money was going to be there. It wasn't reauthorized. They had to stop taking applications. They put children on waiting lists to get the care that they need. We've seen that reoccur in different times when reauthorization has arisen. It is an enormously popular program going almost to its 25th year, and it is time to make it a permanent authorization in terms of the funding.
Well, thank you, Ms. Mann. It is a shame that our children would be used as pawns in a political battle and that they wouldn't have coverage for any period of time. Ms. Mann, can you talk about actions that states had to take after CHIP expired in 2017, including having to send letters to parents warning them that their children may lose coverage?
Absolutely, and this happened also earlier in 2015, and I was at CMS at the time. And on one hand, states struggle with not wanting to give people those notices because they hoped that reauthorization would happen, and they knew how much those notices would cause alarm in those families. And yet, at some point, when that reauthorization did not come through, they had an obligation. They had a legal obligation. They had a moral obligation to let families know what was happening. And then, of course, that caused great consternation in families, wondering how their child would get the care that they need the next week and the next month. So it caused great hardship all around the country, and unnecessarily so, because of the popularity of the program in a bipartisan way. We need to set it on a path where that never happens again.
Well, thank you. And I just want to close by mentioning another program that I think is really great, the home and community-based services that allows people to receive care in their own homes rather than having to go into an institution or a nursing home. We've seen, because of COVID, how that has been even more important. And so just want to continue to work on efforts to expand that and to make sure we provide protections. And with that, Mr. Chairman, I yield back.
Thanks very much. Congresswoman Blunt Rochester, you're recognized for 5 minutes.
Thank you, Mr. Chairman. And I'd also like to thank the witnesses for joining us, and especially Ms. Hatcher, to have you represent the little lobbyist on the 11th anniversary of the Affordable Care Act is just an incredible moment. Access to affordable comprehensive coverage has never been more critical. However, the Trump administration slashed funding by 90% for advertising and outreach for the Affordable Care Act's marketplace options, and refused to establish a broad open enrollment during the COVID-19 pandemic. As a result, enrollment of new consumers in the ACA marketplace dropped 50% in 2021 compared to 2016. According to a survey by the Commonwealth Fund, over 40% of uninsured Americans are unaware of the ACA marketplaces or available subsidies to help pay for coverage. Another survey by the Kaiser Family Foundation found that over half of uninsured consumers were not aware that the ACA marketplace has an actual annual open enrollment. Ms. Keith, can you discuss in more detail how gutting the ACA's advertising budget under the previous administration has impacted enrollment and how investing in outreach efforts and setting enrollment targets impacts new enrollment?
Thank you so much, Congresswoman, for that question. So enrollment through healthcare.gov has been stagnant until this year when there was a huge increase in demand because of the pandemic. So enrollment actually declined year over year. It works well for the folks who are already in it, but as you mentioned, the number of new consumers coming in every year and getting the coverage that they need declines significantly. And that's really where your outreach and marketing and the investments in those funds make a difference. Many studies have shown that bringing in new people, which often tend to be younger and healthier, helps keep a stable marketplace. And I think we lost a lot of opportunities to bring those people in the past few years.
Thank you. It's almost like you anticipated my next question, which was about how help us to understand how advertising and enrollment efforts that help younger and healthier individuals enroll really does have an impact on the cost of care for all Americans and access to affordable coverage. Could you talk a little bit about that?
Yeah, absolutely. I think that's a core part of doing the outreach and enrollment is to make sure that, especially younger and healthier consumers know that these coverage options are available and that it is affordable. I don't think it's hard to understand that older people or maybe people with health conditions know that they need to go and get health insurance. It's where folks are younger or healthier, maybe think they don't need coverage or assume that it's too expensive. They're the ones who need the extra push, and that's who marketing and outreach really helps. Once folks learn the prices, once they learn that they can get good quality coverage, they want that health insurance. It's just a matter of reaching them.
And the American Rescue Plan extended the ACA subsidies to more Americans, including for the first time to individuals with incomes above 400% of the federal poverty line. Millions of families will experience lower premiums and out-of-pocket costs. Ms. Keith, how many uninsured individuals are likely to be eligible for the subsidies under the American Rescue Plan?
The estimates I've seen are that 14.9 million uninsured people qualify, and that includes 3.6 million uninsured people who were above that 400% poverty line. So 3.6 million more middle-income families.
Great. And I understand that uninsured Americans are less likely to be aware of the deadlines and the availability of the coverage, and that the financial this assistance is available. Is that correct?
That is correct.
Thank you, Ms. Keith. And the American Rescue Plan expanded coverage to millions of Americans. However, many consumers still lack basic information about their coverage options. I'm proud to have introduced HR 1872, the More Health Education Act, to invest $100 million annually for outreach and enrollment efforts. My bill will help lower healthcare costs and expand coverage to more Americans, and I urge my colleagues to support it as well as we move forward through this process. Thank you, and I yield back, Mr. Chairman.
Thank you very much. I believe the next member to be recognized for 5 minutes is Congresswoman Schreier.
Thank you, Mr. Chairman, and thank you to all of our witnesses today. On this 11th anniversary of the ACA, I speak as both a pediatrician and a lawmaker when I say, follow the data. Affordable coverage leads to better access to care, which leads to better health outcomes and lower costs, by the way. So I'm thrilled to have my bill, Kids Access to Primary Care, included in this hearing. In my state of Washington, more than 800,000 children access care through Apple Health, our state Medicaid program. And across the country, we know that the provider network for Medicaid patients is really strained. These patients have trouble finding providers who will see them. Physicians cite low reimbursement as the primary reason they are unable to accept additional Medicaid patients. So shoring up this access to care by raising Medicaid reimbursement to match Medicare reimbursement rates will help kids grow up healthier and should play a vital role in reducing the health disparities by reaching underserved populations. So I want to turn to Ms. Mann. In your testimony, you noted that Medicaid access translates into addressing needed care. Can you briefly talk about the importance of access to care and what this means for kids and their future health outcomes and to address some of my colleagues' concerns about cost of care, what early care for children means for long-term costs to our healthcare system.
I'd be glad to. Thank you for the question, Congresswoman. So while access to care in Medicaid is generally very strong in some areas of the country and for some services, there can be access issues, and in many instances that can be traced back to the payment rates, and particularly for primary care and for primary pediatric care. Unfortunately, the rates can be far too low to be able to sustain the services that children need. Just as important to bring in more physicians, I would say also the adequacy of that payment level can help provide that platform for a high-performing pediatric primary care system. One that doesn't take 15 minutes to check out a child, but that really explores the developmental development for the child, works with the parent and the child, understands what's going on at home, whether there's hunger issues and other problems that might impair the individual's health. So in many different ways, primary care is a strong platform for being able to care for kids. And as I'm sure you know, it is so important, particularly for young children. Those investments in care for young children, really, there's lots of evidence showing that it will support that child throughout her childhood as well as as she becomes an adult. And that will, in fact, save dollars. And there's certainly lots of evidence about that. Save healthcare dollars, education dollars, juvenile justice dollars, lots of different parts of the system. It is strengthening our systems of care.
Thank you. I want to quickly turn my attention to something my colleague just asked about, which is that access isn't really access if you can't afford premiums or deductibles. And the middle class has really been left out of so many of the subsidies that expanded care to others, many priced out of the marketplace. And that's why the American Rescue Plan offered tax credits and subsidies to cut premiums for nearly all Americans. In fact, 75% of people on the exchange in Washington state will be helped by this. And an additional 25,000 will gain coverage now because they can afford it. And in fact, an average family of 4 in my district will see their premiums drop from about $14,000 a year to $8,500 a year, which is a significant 40% drop. In fact, one of my own patients' families looked at their $17,000 premiums compared to the $1,400 they would have spent just paying cash, and they just went without coverage. And so, Dr. Keith, could you talk about how the provisions for middle-class families will make healthcare more affordable and how that might also translate to lower costs overall for young families?
Yeah, thank you. And it's exciting to hear that data out of Washington state. So the way that the subsidies will extend for middle income families is no one who's purchasing their own private health insurance will have to spend more than 8.5% of their income towards premiums. It's going to really reduce those costs, as you just suggested, and make coverage much more affordable for people.
Thank you very much. Yield back.
Thank you. Congresswoman Trahan, you're now recognized for 5 minutes.
Well, thank you, Mr. Chairman, and my thanks to each of the witnesses. So many of the questions have, been answered, but I just wanted to sort of say, 4 years before the Affordable Care Act became the law of the land, it was the Commonwealth of Massachusetts that blazed the trail of nearly universal coverage. Our healthcare coverage expansion served as a model for the ACA. Today, the uninsured rate in Massachusetts is about 3%, one of the lowest rates in the country. But not only is healthcare accessible and affordable in Massachusetts, we also consistently rank among the best in the nation for the quality of care that's delivered. And I think it's also worth noting that the expansion of coverage in my state occurred on a bipartisan basis with a Republican governor and a state legislature controlled by Democrats. In other words, Democrats and Republicans can, in fact, work together to enact healthcare programs that maintain quality while expanding coverage. Ms. Keith, like so many members on this committee, I am deeply concerned about the inequities in healthcare accessibility and affordability. Fortunately, the American Rescue Plan enhanced the ACA's subsidies and significantly lowered premiums for Americans. And the American Rescue Plan also significantly reduces premiums for individuals already eligible for coverage and extend the ACA subsidies to Americans who are currently uninsured. Can you briefly discuss how these enhanced subsidies help make coverage even more affordable and accessible?
Thank you for that terrific question. So the enhanced subsidies are going to not only save people monthly premiums and what they would otherwise be paying, I do want to emphasize that many folks will have the opportunity to buy an even more comprehensive plan with a lower deductible and lower out-of-pocket costs. So the subsidies are focused on the premiums, but it's actually going to give people even more buying power to go and get the even more significant financial protection that they need. And you're exactly right, that extends up and down the entire income scale. I really can't emphasize enough how transformative this is going to be for millions of people.
Terrific. And we're excited about expanding upon that as well. You know, Dr. Schreier, she touched upon the Medicaid expansion and how that is going to benefit our children. So with the remaining time that I have, I'd like to turn to another important issue, which is the expansion of coverage to treat substance and opioid use disorder. You know, many of the states that have been hardest hit by the opioid epidemic have not expanded Medicaid. So Ms. Mann, you briefly touched on this earlier in this hearing. Could you explain how the expansion of Medicaid increases access to treatment and care for those suffering from opioid use disorder?
Sure. If you think about a state that has not covered any of their childless adults, right, not done the expansion, and for whom even parents are covered at very, very low income levels. The median state, it's at of non-expansion states, it's at 40% of the poverty line, and when you earn anything above that amount, you become ineligible for coverage. So with that extent of a coverage gap, what it means is that the only way people can get services and care if they have a substance use disorder is through charity care, through uncompensated care, or maybe if a state has some some treatment or community treatment centers that it's paying for with its own dollars, which will generally mean it's quite limited. As states have expanded Medicaid coverage, they have brought in millions of people into coverage, and that allows them access to all the care they need, whether it's primary care, whether it's cancer screenings, or whether it's substance use disorder treatment. And we have seen the states that have expanded coverage really do the most in terms of providing those services.
Great. Well, I want to thank you for your thoughtful answers to these questions. I think it's clear from the testimony that Medicaid expansion offers tremendous benefits, and it's cost effective and provides quality, affordable care to those in most need. I'm proud that my state made this decision early on to expand Medicaid coverage, and I hope the remaining states will make that same decision. Thank you, Mr. Chairman. I yield back.
Thank you, Madam Chair. I'm going to yield the virtual gavel back to you. I believe Congressman Burgess is next in line, but I'll give it to you. Thank you.
Thank you. Thank you very much, John. Appreciate it. I was gone a little longer than I anticipated, but that's what happens when there are many members of Congress that are part of a meeting. It gets stretched out. Pleasure to recognize Dr. Burgess of Texas for your 5 minutes of questions.
Good deal. Thank you for the recognition. And I also apologize to our panel. There are 3 different hearings that I'm a part of this morning, so it's been a little difficult to balance between health, budget, and the Rules Committee. But this is important, and I'd like to ask Dean Cameron, you note in your written testimony, while it's not necessarily right for everyone, short-term plans can be a helpful alternative for individuals in certain situations. You know, I'm reminded of there's a Fox News bureau down in Dallas that I will sometimes I'll be tasked with going down and giving an interview, and the fellow there that controls the microphones and gets you seated and make sure the shot's right asked me after one of my interviews that was about healthcare. He said, "I hope you're going to do something about this." This was before the individual mandate was zeroed out. He said, "Because I've got to pay a fine, and then and I'm able to buy a non-compliant insurance policy that actually covers what I need." And I couldn't help but think, we haven't really done this individual any great favor by fining him and then turning him loose to buy the actual coverage that he needs. So, Mr. Cameron, I wonder if you could expand upon and kind of walk us through what additional benefit we might see from keeping the short-term limited duration plans.
Well, thank you for the question. First and foremost, I think you give choices to consumers who can't afford the ACA plans. And in spite of the adjustments that have been made in APTC here recently, there's still a large segment of the population in Idaho who won't qualify, particularly those that are younger. I looked the other day, we run studies of those that would get the enhanced APTC, and they are 50-year-olds and families of 4. Whereas if you're 25, married to a 25-year-old, you don't get anything. And so those individuals, those healthy individuals, really need someplace to go. And so from our approach, we think making, and I think it's a legitimate question as to what benefits short-term plans should have, and what are the requirements. So that's a legitimate debate and question, and one that I think many state insurance commissioners are addressing and working with their legislators on. And I commend them for their efforts. I think individuals who don't have choice end up going without coverage. Their conditions that come up end up going undiagnosed and untreated. And so then they wait and come on to the ACA plans when they've got a condition. They wait until that case, and then that makes it more expensive. If you think about it, and I know it's an overused axiom, but if everybody waited to buy homeowners insurance to when their house was on fire, it would be tremendously expensive. So we've got to figure out ways to get everybody involved, the young and the healthy, in the same risk pool. That's what we've done here in Idaho, is trying to get even those that are on those enhanced short-term plans, they're in the same risk pool with the ACA, which it will help us hold costs down to those that are purchasing on the exchange.
That's terribly intriguing concept, and one that I hope this committee will spend some time studying. Let me just ask you, Mr. Cameron, Section 1332 waivers, they're actually part of the Affordable Care Act. The Trump administration was criticized for using 1332 waivers, but 1332 waivers were actually written into law. They were, as the way the law was written, they were delayed, so they wouldn't go into effect until January of 2017 for reasons that I don't completely understand. But have you had any thoughts about the 1332 waivers?
Yeah, thank you, Congressman. We do. We have very strong opinions about the 1332 waivers. We think they ought to be there, but we think they ought to be allowed to use states to become sort of the laboratories of intervention and creativity. In our experience, even under both administrations, the provisions of the 1332 made it very difficult, particularly for rural small states, to participate and to utilize. Larger states could get the 1332 waivers. We actually even applied for 1115 and a 1332 combined. We called them a dual waiver approach, which was going to help reduce costs both to the federal government and to the state, reduce premiums by 25%, and yet we couldn't quite get that across the finish line because of the strict interpretation. So we encourage additional flexibility in 1332 waivers.
I think that's an excellent point and one that we should look to. So you only pay for what you need. What an interesting concept. I thank the chair. I'll yield back.
The gentleman yields back. I now will recognize the gentlewoman from Minnesota, Angie Craig. Are you there? Oh, I'm sorry. All right. The gentlewoman from Texas, Ms. Fletcher. Lovely to see you. Thank you for your
Lovely
patience.
to see you. Thank you so much, Chairwoman Eshoo. Thank you for recognizing me now and for holding this hearing. It's been incredibly helpful to me listening. And of course, we focused on so many important provisions and achievements that we have been able to make because of the important provisions of the ACA on this anniversary, and also identified some of the areas of improvement certainly that are needed. And so it's been an incredibly helpful hearing. I'm also glad that we focused on the American Rescue Plan and a provision, a really important provision that was actually from my bill, HR 871, the Expand Medicaid Now Act, to provide generous new financial incentives to states to expand Medicaid. And I'm so glad to see that states are seriously looking at expansion, as Ms. Mann noted in her opening statement, and again, with questions. In my home state of Texas, this provision would result in billions of federal dollars going to our state. And it is the state with the highest uninsured rate in the country. And we know that so many Texans are living in this coverage gap, that there's real and meaningful coverage expansion that we desperately need here in Texas. So, while I hope that the bill that's included in the rescue plan will provide the incentive to the remaining states, the non-expansion states, I am somewhat worried that other states will continue, and my own state, hopefully not, but may continue to refuse to expand. And so for that reason, I wonder about the other options that exist to expand access, and I wanted to focus my questions on those. I understand that from 2007 to 2010, first for select counties, and then further expanded in 2010 to all counties. California allowed counties to expand Medicaid coverage through a Section 1115 demonstration project. These individuals were later transitioned into the statewide expansion established under the ACA. Similarly, from 2012 to 2014, Cook County in Illinois also had an 1115 demonstration project creating Medicaid expansion for county residents who were then moved into the statewide program. My county that I live in, Harris County, is the third largest county in the United States after Los Angeles County and Cook County. And so, a similar expansion project is, of course, of interest to me conceptually as we're thinking about this. There was a similar demonstration project, I understand, in Cuyahoga County, Ohio. And so those kinds of projects could provide a model for new county demonstration projects in states like Florida and Texas and elsewhere. So I want to direct my questions on this topic to Ms. Mann. First of all, can you talk a little bit about how a county expansion project might complement the additional expansion incentives we included in the American Rescue Plan? And then, just because I've talked for a while, I just want you in your comments to also talk a little bit about the expansion in the American Rescue Plan. I think some people may think that the 5 percentage point increase isn't a large number. So in the context of your discussion, can you also explain why that's a good deal for states as you share your thoughts with us on expansion and these potential other avenues for expansion?
Absolutely, I'd be glad to do that, Congresswoman. Thank you for your question. There are the American Recovery Plan has provided a really strong incentive for states to reconsider that have not yet expanded coverage, to say now may be the time. Now may be the time because so many people are uninsured and so many people are having health issues because of the pandemic. But now is the time in Texas because there's so many individuals who just don't have insurance, both percentage wise and number wise. It's the largest in the country. And because of that, the Kaiser Family Foundation has estimated that the 12 states together will get about $9.6 billion should they all go forward and expand coverage. And Texas will get the lion's share of those dollars because of the size of the uninsured population and the extent in their program. The 5% is a large amount of money because it is not for the expansion group. The 5% is for all expenditures in your Medicaid program. And so the base upon which it applies is a much larger base. For Texas, it includes the coverage they're providing for people with disabilities and elderly. So it's a very large amount of money. In terms of thinking about counties moving forward, you're absolutely right. There have been instances in the past. They were all pre-ACA, or at least the effective date of the ACA, but they really did provide coverage and they really did help get states and communities ready for full statewide Medicaid expansion. I'm, heartened that everybody in Texas is continuing, or many people in Texas are continuing to think about the ways in which coverage expansion in Medicaid can come to the Lone Star State. Hopefully the American Recovery Plan incentive will do the job, but it's really good to hear that people are thinking about lots of different options.
Well, thank you so much for that. I appreciate your testimony and the testimony of all of our witnesses today. I have exceeded my time. Chairwoman Eshoo, thank you so much, and I will yield back.
Thank you for your patience. I don't see any Republicans that to call on, so I'll go next to and recognize the gentlewoman from Minnesota, Angie Craig. Is Angie there? No. Okay. Not seeing Ms. Craig, we'll now go to members that are members of the full committee, not members of the subcommittee, but we welcome them. And they are waving on, and I'll recognize the gentleman from Illinois, Mr. Rush, for 5 minutes of questions.
Want to thank you, Madam Chair. Thank you for allowing me to participate in today's hearing on the ACA. Especially,
you're always welcome. You're always welcome.
Thank you so much, especially on this occasion of the 11th anniversary. I was proud, as you were, to vote for the ACA in 2010, which has since become a lifeline for millions of Americans. I was also pleased last month to vote for the American Rescue Plan, which delivered on Democrats' promise to strengthen the ACA and make health care more affordable for all Americans. The improvements included in the American Rescue Plan and in the legislation that we are considering today are long overdue and cannot come soon enough. In 2020, it was estimated that 846,000 Illinoisans lost employer-sponsored insurance. During a global pandemic, it is critical that we ensure everyone that has access to high-quality, affordable health care. COVID-19 has revealed a bright light on healthcare disparities, which are too common for Black and brown Americans in my district and around this nation. It is our duty to ensure that we conduct outreach to African Americans, to Latinos, to Asians, those who are more likely to have negative health outcomes from COVID-19. A Gallup survey conducted last year found that non-white adults were more than 2 times as likely to seek, to defer seeking treatment for COVID-19-like symptoms due to health than those who are white Americans. Access to affordable health care insurance will reduce this disparity. Fortunately, the American Rescue Plan temporarily extends the marketplace premium tax credit to more individuals for 2021 and 2022. That said, Ms. Keith, are these increased subsidies available now for 21 for those already enrolled in the plan for 2021 through healthcare.gov? What actions, if any, are needed for these consumers to receive the subsidies for which they now qualify for?
Thank you so much, Congressman, and thank you for your leadership on all of these issues. So the subsidies that you're talking about will be available through healthcare.gov beginning on April 1st. And federal officials are encouraging everyone who already has coverage or needs coverage to go back into the system and make sure that you say, yes, I want to take advantage of these credits. It's also the moment, though, to see if you want to change plans and maybe lower your deductible or lower your out-of-pocket costs. It's really a moment to shop around, get the best deal for you, and take care of your healthcare. And I haven't said this yet, so I will emphasize anyone who's uninsured or needs healthcare or health coverage can enroll through healthcare.gov through May 15th. Really, really important to get the word out. Thank you.
All right. Ensuring affordability of high quality health care, as I said before, is a top priority. And I have been an outspoken opponent of short-term, limited duration insurance. These job plans are often sold to patients by unscrupulous sales representatives who do not disclose the gaps in coverage, which can leave patients on the hook for literally thousands of dollars. Ms. Keith, are there any demographic breakdowns based on race for short-term, limited duration plan enrollment?
None that I'm aware of. No, sir. The best data that we have really comes from the committee's year-long investigation of the practices for these products.
Well,
Okay.
Madam Chair, it seems like my time is running out, and I yield back the balance of my time. And thank you again for your consideration and for your grace and mercy.
You're wonderful. You're always welcome. I think it is an eloquent statement about our subcommittee that we have always have members that want to wave on. So each one of you is always welcome. Pleasure to recognize Ms. Chakowski of Illinois waving on for 5 minutes of questions, and your patience as well, because you've been on board since before we began this morning. So you have the benefit of hearing all the questions and all the answers. Welcome.
Well, thank you, Madam Chair, and I also am just grateful for the opportunity to wave on, and happy 11th anniversary to the Affordable Care Act. And I was so proud to help craft it as a member of this subcommittee, the Health Subcommittee, and to be a member of the Energy and Commerce Committee to actually get this done. And I've heard many wonderful, life-changing stories that people have experienced because of the ACA, and I want to just acknowledge the words of Laura Hatcher, and thank you so much for your words and sharing your experience, but also for the little lobbyists who we've seen in the Capitol for a long time. And it's just been priceless, that the influence that they have. But still, we can definitely make improvements. In Illinois, we had a problem with network adequacy. That was actually for a while. It's better now, but for a while, many Affordable Care Act plans did not include any of the major hospital or affiliated doctors in the Chicago area. And while the law absolutely says that there must include inclusive adequacy networks and access to specialists, it didn't happen. And so, Professor Keith, I wanted to ask you, can you speak to the importance of network standards to ensure that patients are able to have a good number of choices and have the doctors and the providers that are really needed for them in particularly?
Thank you for that very important question. So you're right, the Affordable Care Act included network adequacy standards. I think many people have started encouraging what we call quantitative network adequacy standards, which really say that a patient should be able to find a primary care physician or a specialist or a hospital within a certain distance from their home or where they work. And this is the idea that folks should have good access to actual providers in their neighborhood or close to them. An example would be being able to find a primary care physician within 10 miles or 15 minutes, and those standards would change based on rural, urban, or suburban areas, things like that. So really a way to include access to actual healthcare providers.
So the key word is quantitative, and let's hope that we can get there. I want to also mention to you that some states actually have the authority to lower premiums if they are felt to be exorbitant. Illinois is not one of those states. We can oversee, but we cannot do anything actually to change that. We can review these numbers. And so I wanted to ask you, is it, can we require, when we improve this act, to make sure that all states are able to look at and review these rates and make adjustments to the rates?
Certainly. So the Affordable Care Act included what we call rate review standards, but you're exactly right. Not every state has what we call prior approval authority, meaning they can actually deny the rate that an insurance company wants to use before it goes forward. I think there's been a lot of focus today on healthcare costs. I think rate review is one way that state regulators and federal regulators could really leverage and put pressure on insurance companies to help bring down healthcare costs. The whole goal here is to make sure that costs are fully justified and that consumers aren't, paying more than they should be paying. I think it's a huge consumer protection.
Absolutely. So I just wanted to say that my bill that's in this packet, HB 1890, the Healthcare Consumer Protection Act, has two things that I was just really talking about: to set network adequacy in the way that you described, to make sure that everyone can have access, and to make it standard, to set network adequacy standards. And I guess my bill says that CMS would do that. And secondly, to permit all states to be able to address the excessive rates by actually requiring a reduction in those rates. I know that there are many times that it would have been very helpful to us in Illinois not to just comment on it, not just to be reviewing it, but to have some actual power. So I am almost out of time, and I want to thank all of the wonderful panelists for being here. And it's been an honor to be able to wave on to your committee, Madam Chair, and I yield back.
Well, we thank you. I see that the gentlewoman from Minnesota is back on the screen and with us. So I recognize the gentlewoman from Minnesota, Ms. Craig, for your 5 minutes, and thanks for your patience. And I also note that Mr. Vesey has joined us and will wave on. So I just want you to know that I see you there, and you'll be coming up after Ms. Craig. So away we go with Minnesota.
Thank you so much, Chairwoman Eshoo, for yielding, and thank you to the witnesses for your resilience here during this testimony today. The ACA, in my mind, led to historic coverage gains and put in place important and meaningful consumer protections. Over 100,000 Minnesotans enrolled in health coverage through the ACA marketplaces in 2020, and 59,000 Minnesotans received tax subsidies to make their health care more affordable. Those Minnesotans include hardworking small business owners like Ali Hatoum, owner of Morning Glory Bakery in Rosemount. The ACA enabled Ali to secure affordable coverage for himself and his family, and to put the resulting savings back into his business. Today, we are building on that work to further lower healthcare costs and expand coverage for my constituents and all Americans. So I want to start with Ms. Keith here this afternoon. The ACA, as you mentioned in your testimony, established a temporary reinsurance program. Can you talk a little bit more about how that program helps to reduce premiums and the benefits of such a program in our states?
Yes, thank you for that question. So the temporary reinsurance program for the ACA was in place from 2014 to 2016. And while it varied year by year, that program was responsible for reducing premiums anywhere from 4 to 14%. I would also add that we've seen 15 states use Section 1332 waivers that have been discussed today to do their own state-based reinsurance programs. And as of 2020, the 12 states that had those programs in place had reduced premiums by about 18%. So these programs do allow for significant premium savings.
Thank you so much. I know that reinsurance helps to pay for the cost of those most high-risk patients in the pool, those with serious medical conditions, thereby reducing the premiums for all individuals. But can you talk just a little bit more about how reinsurance works? This is something that I want to make sure my colleagues on the committee understand, as well as my constituents. And then maybe just more broadly, what other measures would be effective in lowering premiums and out-of-pocket costs?
Certainly. So reinsurance can be designed in a number of ways, but at its core, it's about providing funding to help offset high claims, as you've mentioned. This is really a way of giving insurance companies stability so that they're not all raising premiums and pricing, expecting to get the people with the highest, most costly pre-existing conditions. Once insurance companies know that they will have some of those claims offset, they can drop premiums for everyone. So they're not all pricing like they're going to get someone who's really, really sick. It just provides that market stability that insurance companies are looking for. And I will say, we use reinsurance in other federal programs as well. Medicare Part D, for instance, it's a non-controversial program in our other federal coverage programs.
Yeah, thank you for adding that. I often say that flood insurance, crop insurance, other types of insurance also have reinsurance as part of those policies, and often can't understand how they get involved in sort of political debate, since that's just a normal, non-controversial part of an insurance plan. Can you also just talk a little bit more, perhaps, about some of the other measures that you think would lower premiums for folks in the individual marketplace in particular, and what else we could be doing to lower out-of-pocket costs for our constituents?
Certainly. So this is an area where I'm very excited about state experimentation. We've heard a lot about state labs of innovation, and I think providing states with additional federal funding to lower healthcare costs, to lower patient out-of-pocket costs, to experiment in ways and advance health equity, I think is the direction we should be going in. We've seen a number of states, California, Massachusetts, Vermont, New Jersey, I'm probably missing some, who've actually decided to sort of directly help subsidize patient costs and build upon those programs. I think there's a whole range of options, and it would be great to really unleash states and see what they could do, building off of the Affordable Care Act as a framework.
Thank you so much, Ms. Keith. It won't surprise you to learn that the reinsurance proposal is my bill that I'm carrying here in the U.S. House of Representatives. And again, I see this as super common sense, straightforward policy that will help us bring down cost and reduce risk. So I encourage my colleagues on both sides of the aisle to co-sponsor the bill and to support reinsurance. Thank you so much. And Madam Chair, I yield back.
Thank you, Congresswoman Craig. And I think that all the members of our subcommittee have a special appreciation for the new members that have come to our subcommittee. Great, crisp, new ideas, all the energy in the world. So they're on display. You've heard them, and we're all really collectively proud. And you've got an important bill there. Now, let's see, who's next? We'll go to the gentleman from Texas, Mr. Vesey, who is also waving on, and you're always welcome at our subcommittee, and you're recognized for 5 minutes of questions.
Madam Chair, thank you very much. I appreciate you letting me wave on and want to talk about this because this is hugely important. You know, Medicaid has done a lot, particularly after the ACA was passed, for so many different states, but there are still 12 states in the union that haven't expanded Medicaid. And my state of Texas, the Lone Star State, We're one of those 12. And it's really sad because even though over the last 10 years, we've had a tremendous amount of economic growth all around the state, including here in the Dallas-Fort Worth Metroplex, we still have over 1 million uninsured just here in the DFW area, the district that I represent. I have about a third or more of the constituents that I represent that don't have healthcare insurance. It's really that bad. And so that's one of the reasons why I'm proud that the legislation incentivizing Medicaid Expansion Act that I introduced is part of today's discussion, because the bill would establish incentives to expand Medicaid by providing states with 100% matching fund rates for expansion during the first 3 years and gradually decline the rates to 93% by year 6 of expansion. And I think that this bill is really important now because of what we've seen as it relates to COVID-19 and how it's really hurt our state because of so much mismanagement. I wanted to ask specifically Cindy Mann. Cindy, we have 7 years of data, and we've been able to look at Medicaid expansion and the impact that it's had on the country. Have researchers found any positive health effects of Medicaid expansion? Because I know that there's been a lot of talk about people being able to finally see physicians on a regular basis, and I was wondering if y'all could tackle that.
Absolutely, and what an important question. And I'm hopeful, Congressman, that Texas policymakers will see the new incentive as an opportunity to rethink their decisions about Medicaid expansion. So we have, with the anniversary of 11 years and coverage being in effect since 2014, there's lots of evidence and research, and it continues to mount showing the health impacts and value of coverage generally and of the Medicaid expansion in particular. We've seen cancer screening rates and cancer treatment rates increase among the expansion population. Certainly see people being able to access behavioral health services and services for substance use disorders that otherwise weren't available to them. We've seen the ability for people with chronic illnesses to be able to get those illnesses managed. And we've seen reductions in low birth weight babies. We've seen reductions in maternal morbidity. There's really been a gamut of kinds of changes that you might expect when suddenly a population that historically has been marginalized and underserved begins to be able to access the care that they need.
At this point, when you take that data that you just spoke about and you look at all the other benefits, is there any legitimate reason, if you were Greg Abbott and you're sitting in Austin, Texas right now, is there any legitimate reason to continue to deny people the right to be able to access Medicaid expansion?
Well, I'm sure Governor Abbott has reasons, and it's far from me to say that his reasons are not legitimate. But as I see the evidence, and the evidence again has been very strong and very mounting, it has been an undeniable success, and the evidence all points to the value of going forward. And we have seen 36 states go forward. 2 additional ones are coming forward in July who passed ballot questions. It's a very popular change in the states, and not one of those states, no matter what the political makeup is of the state policymakers, not one of those states have decided not really a good deal, not really helpful for my residents or my providers or for my state budget. They've all retained Medicaid expansion and continue. So that's voting with their feet.
Yeah, thank you very much. And Madam Chair, let me say this in closing, that oftentimes during this argument about Medicaid expansion and other services that are similar to that, the constituents like the ones that I represent a district that's heavily Hispanic and Black. And oftentimes their story is told of people that are working hard to support people like the ones that live in my district at their expense, and they become the foil for this narrative that you hear over and over again. But this Medicaid expansion would not only help constituents like I represent, but many of the ones that consider themselves Republicans that live in their districts too. And I want to be clear about that, 100% clear about that. This is something that has helped a lot of Americans, and we need to try and expand it, especially in states like mine that are growing so rapidly. Thank you.
Thank you, Mr. VC. Each member that waved on are value added to today's hearing. I don't see any other virtual hands raised, so to each one of our witnesses, thank you. We're very, very grateful to you. To Katie Keith, Dean Cameron, you're always welcome at our committee. You've testified before. We always welcome you. To Cindy Mann, we've called on you. I knew Chuck Manette many, many years ago. So, you know, his leadership is still around. He'd be really proud of you, as we all are. To Marnie Jameson Carey, thank you for your excellent testimony. To Laura LeBrun Hatcher, thank you. And give our best to Simon. Tell Simon that that we're with him, we stand with him, and we thank him for everything he's done for telling his story. The little lobbyists are giants, really. You know, I started out this morning in my opening statement talking about the letter that Senator Kennedy wrote before he died, that the letter would, it was to President Obama, and that it was not to be open until he went to heaven. And that letter, I have read and reread many times. I think that the cause that Senator Kennedy spoke of in that letter, of ensuring that the state of a family's health will never again depend on the amount of a family's wealth, was the great unfinished business of our society. I think that together this morning, even though we have differences of opinion on various parts of this, that we have really moved the needle. We're in the process of moving the needle again to make good on that cause of ensuring. So I want to thank all the members for the time investment they made today, the excellent questions, both sides of the aisle, our witnesses, and that together that we will really reach that North Star of every American having good health insurance, not only access to it, but that they can afford it. That's certainly has been the North Star of my public service, and I think it is for others as well. So from a very deep place in my congressional heart, I thank each one of you. Now to my pal, the ranking member of the subcommittee, we have 21 documents that need to be entered into the record. So I'd like to ask you for unanimous consent, unless you want to
My choice is to have you read all 21, right?
all 21 documents.
Yeah, much as I've enjoyed our time together and great testimony and questions, I will give unanimous consent that we dispense of reading them.
And I thank the gentleman. We'll submit these for the record, and pursuant to committee rules, members do have 10 business days to submit additional questions for the record. And I know that the witnesses welcome those questions, and we ask that you respond as promptly as you can to the questions that any of the members submit to you. And with all of my thanks to everyone at this time, the subcommittee is adjourned. So I think I'll use my coffee cup as the mug. Our meeting is adjourned. Thank you, everyone, and happy anniversary, ACA. Thank you.